So very good morning to all of you. Wish you a very, very happy New Year 2025. And this is IAPS NextGen 2025. This time it is different from the previous session, like 2024 session, which was a weekly session, and it was not a very comprehensive one because there were only case presentations. So this time we have tried to emulate exactly like an exam, having a theory paper, long case, short cases, and table vivas. So this is all based on the inputs of postgraduates which I received in last year. I'm extremely thankful for to all the examiners for giving their valuable time and coming and guiding us. Two engines of this event are Dr. Kanishka Das and Dr. Arvind Sinha, who has helped me to prepare a very good program and good quizzes, and I'm really thankful to them. So now, without wasting any more time, I hand it over to Dr. Prakash Agarwal sir and Savitri for case presentation, which is a long case on hepatoblastoma.
Sir, I think one of us, you have to make the host, sir, not co-host, so that I can make the other person co-host.
Okay,
Like last time.
I made you host.
Yes.
Is Savitri able to share her screen?
Yes, sir, I'm trying, sir.
Biswas sir has joined everything.
So by the time Savitri gets the sharing rights, may I request our respected president, Professor Dr. Sumit Biswas, to say few words and deliver a welcome address.
What?
Biswas sir, good morning.
Good morning. Good morning to everybody present here. I wish all of you a happy new year and also congratulations to all the candidates for successfully completed their theory exam and then appearing for Viva Voce. I wish them, all of them, very good outcome of their result. Thank you.
Thank you, sir.
Thank you.
So your screen is now getting shared, Savitri, I guess.
Yes.
You need to open the PowerPoint. Yeah. So make sure you limit your presentation to the allotted time so that more discussion can happen.
Yes, sir.
Yeah. Yeah, it's visible. You can just start the slideshow.
Okay, sir.
This is.
Who is Dr. Shobha?
No, she opened a wrong presentation, I guess.
No, sir, this is different. Someone else screen is sharing.
No.
The screen which
Have
we are
you-
seeing is your screen?
Have you been allowed screen sharing or no? Savitri has to be allowed. Vinay?
Yes, sir, I have made her co-host. Savitri, now you can share your screen. I made you co-host.
Savitri, are you?
What we
I
can
think
do, we
she's
will
not.
ask the presenters to give their PPT to you also.
Yes, sir.
So this problem can be sorted out so that we can start
Okay,
playing
sir.
the PPT from there and they can start speaking.
I'll add in that WhatsApp group where presenters are there and you can get it there. Savitri, are you there?
Yes, sir,
I
I'm
think
there, sir.
So have you got the screen sharing rights?
No,
Yes?
sir, I'm unable to share.
now you can share. Just accept it.
Okay,
Yeah,
sir.
you are now co-host. It is showing on my screen. Are, are you able to share? I mean, have you got the screen sharing rights? I need a reply, beta.
I think she left the meeting, sir. Some network error might be there.
He must be trying to log in.
Yes, sir.
She put her presentation here, Vinay.
Yes, sir. I'll share. Yeah.
You are there in the group or no?
I'm there, sir.
Yeah, please share.
Just drop.
I'm sorry for this delay, but once it is start happening, then there is no problem. Then everyone gets on the roll.
Hello.
Yeah.
Sir, I'm unable to share. I put the presentation in group.
Yeah. I'm sharing it. Which one? The first one or the second one? The lumbosacral?
No.
No, sir.
Wait, I'm wrong.
Presentation 19.
19.
19.
Okay, make it full screen.
Yes, sir.
Click that one first. Presentation. Go to slideshow. Yeah, make it slideshow.
Yes, Savitri, now we can proceed.
Yeah.
Yes, sir. Good morning, sir. I'm going to present a case on abdominal mass. My case is 1-year-old female child, resident of Kadlur, Tamil Nadu. Informant is mother, reliable. The mother brought the child with a complaining of abdominal mass noticed since 2 months while bathing the child. Baby was apparently all right 2 months back. Then mother noticed the abdominal mass 2 months back, which is insidious in onset, gradually progressive to present size, and mother told it is presently on mainly on the right side of the abdomen.
कहाँ पे रखो ये दोनों
There is no history of
इसको
fever and pain,
I
no
request
history of
all
trauma,
other participants who are not speaking to please mute your mic. Please be careful about this.
no history of abdominal pain, vomiting and bowel disturbances, no history of urine discoloration or crying during micturition or hematuria, no history of yellowish discoloration of sclera or skin. So next type. No history of bleeding, no history of change in position of mass, no history of decrease in appetite, no history of failure to thrive, no history of any antenatal detected congenital anomaly,
Vinay, can you move to the next slide?
no antenatal history. This is a non-consanguineous marriage, registered pregnancy. All antenatal scans were normal. Natal, the second born child out of LSES, full term, birth weight 2.5 kg. No history of NICU or hospital stay and immunized up to date. On history, my summary is 1-year-old female child brought by mother with a complaining of abdominal mass noted since 2 months, which is gradually increasing in size, and no other significant negative history present. And proceeding to on examination, child examined in a well-lit light, exposed from nipple to mid-thigh. Child is active, alert and playful, paler present, no icterus, cyanosis, clubbing, lymphadenopathy and edema. Pulse rate is 100 beats per minute, BP 90 to 46, which is 50 to 90 percentile. Saturation maintaining on room air, respiratory rate 30 breath per minute. Weight is 6.9 kg, which is less than third centile, and height is 67 centimeter, which is less than third centile. Going to systemic examination. On inspection, abdomen is protuberant more on the right side. Umbilicus inverted is displaced downward. Mass of 17 to 17 seen in a right hypochondrium and in the epigastric region and right lumbar region. Medial and inferior border appears defined. Skin over the mass appears little stretched. Dilated veins seen over the epigastric region. All quadrants move equal with respiration. Hernial orifice appear normal. No renal angle fullness visible. On palpation, mass, no local rise of temperature. A mass of a size 17 into 7 centimeter, palpable in the right hypochondriac region, extend to epigastric and the right lumbar region. Mass is hard in consistency. The surface of the mass is nodular. Lower and medial border are well defined. Mass is 7 centimeter below the posterior margin. Swelling, the mass moves with the respiration. Upper body is continuation with the liver as we are unable to insinuate a finger or the subcostal margin. Laterally, border is not palpable beyond the posterior axillary line. And there is no renal angle fullness, no splenomegaly. Percussion, dull note over the mass present. Liver span is 13 centimeter. Auscultation, no bruit heard over the mass and bowel sounds present. Spine grossly appears normal, genitally normal, and other systemic examinations appear normal. My summary is 1-year-old female malnourished child brought with a complaining of abdominal mass since 2 months with no other significant negative and natal history. On examination, 17 into 7 centimeter hard mass, palpable right hypochondrium, epigastric and right lumbar region with a well-defined medial and inferior border with nodular surface and upper border in continuation with liver. Probably a malignant liver region, most likely to be hepatoblastoma.
Okay. We'll come to the blood investigations later. So in the inspection, you told about the size of the mass and the irregular surface. Can you comment that on the inspection findings?
No, say, no skin over the surface second.
No, you had written in the inspection that the mass was 17 into 7 centimeters and the margins were irregular. I don't think you can tell that on the inspection findings. If you
Yes,
go
sir.
back to the slide,
Just
that
yes, sir.
you have
Only
to
vague
just
mass.
tell approximately there is a vague mass and approximately what is the size. Whatever is your
Okay, sir.
palpatory findings, you are telling that in the inspectory findings exactly the same in dimensions, which is not correct. So you should tell a vague mass is seen in the right hypochondrium, and then in the palpation you can tell the exact dimensions and whether it's
Yes, sir.
irregular or soft or irregular. Okay.
Yes, sir. I
The
was in
other thing is
doubtful.
okay, fine. Next thing is what is the differential diagnosis? What else it can be apart from hepatoblastoma?
On history, my differential diagnosis can be a liver mass.
Please go ahead.
First is a liver mass, other one is a renal mass, or anything retroperitoneal lesion, or
Even if it's a liver mass, what else it can be apart from hepatoblastoma?
infantile hemangioma, sir. Hepatoma.
Hemangioendothelioma or hemangioma
Yes, sir.
or mesenchymal hematoma. So you should
Yes,
tell all the
symptom.
benign pathologies also along with the
Yes.
malignant ones.
Okay,
Okay.
sir.
Liver mass means
Yes,
what
sir.
it can be liver mass? What liver mass
Means
can
it can be
present?
benign or malignant. Yes, sir. It can be benign or malignant.
Yeah. Liver mass, what? Renal mass, you are telling, no? It's another differential diagnosis. What
Yes, sir.
another renal mass it can be in that area?
It can be a hydronephrosis also, sir.
Okay.
Hydronephrotic kidney or neuroblastoma or
Neuroblastoma is a
nephroblastoma.
renal mass?
No, sir, that retroperitoneal mass, nephroblastoma can be there.
Yeah. So you should tell all the differential diagnosis when you're telling probably a malignant lesion of the can be a hepatoblastoma. Other differential diagnosis you should also have it in mind and not stick to one diagnosis. Then we have to
Yes, sir.
differentiate one from the another.
Yes,
Now
sir.
tell me how will you proceed with this case?
This I'll proceed like to proceed with blood investigations and radiological investigations, sir.
What specific blood investigations you will do?
Specific blood investigation alpha protein and beta HGG. I would like to know, sir.
What will alpha fetoprotein tell and what will beta HCG tell?
Alpha protein will tell if alpha fetoprotein is raised. It tells that it is a malignant tumor, most likely hepatoblastoma, which is raised in hepatoblastoma. And if it is a beta SCG is also raised, it may tell about it it is a germ cell line tumor.
So both may not be positive, no? Either alpha
Yes, sir.
fetoprotein is positive or beta
Yes,
HCG is
either or
positive.
one. Yes, sir. In this
So
case,
yeah,
in this
please go
case,
ahead.
alpha fetoprotein was 9,80,000. Next, 9,48,700.
Yeah. So how much you expect it to be around in this age group?
In this, at 1 year of age group, it will be around 4,000 to 50,000 with a mean of 9,000. It will be this.
Okay. So alpha fetoprotein is suggesting of a hepatoblastoma. What else you will go ahead to do to confirm your diagnosis?
I'll go ahead to do with first ultrasound of the abdomen and pelvis, sir, to know confirm the organ of origin about the lesion and its dimension and its relations and
Okay.
how is the lesion on ultrasonography. So on
Fine.
ultrasonography,
Yes.
a large heterogeneous multilobulated lesion with the internal vascularity seen replacing the left lobe, the anterior segment of the right lobe of a liver, measuring 8.5 into 11.5 into 9.3 centimeter. Multiple curvilinear calcific foci seen within the lesion.
Right. So this also is suggestive of a hepatoblastoma. So what else you will do? How will you
Next, I
manage
would
it
look.
now?
Next, I would like to go ahead with the computed contrast and computed tomography of thorax and abdomen, sir,
For what?
for pretext staging, sir,
Very good.
and to know the
Okay.
staging and to further plan for further treatments.
Okay. So this is the CT scan of the child.
Yes, sir.
Can you read the CT scan? What does it show?
A large mass occupying the right anterior right part of the liver and the left is seen, sir. The right posterior part of the liver is spared and the left medial part of the liver is spared, sir. And it is a heterogeneous multilobulated lesion with hyper-enhancing and hypo-enhancing in between and calcific lesions also seen. And with a sparing of right posterior segment, sir.
So which all segments it is involving?
It is involving left medial section, that is fourth, and right anterior 5 and 8 are involved, sir.
Now tell me again, what are the segments involved?
Left lateral section 4, segment 4, sir, and right anterior 5 and 8.
Can you show with your arrow which are the segments? On the cursor, can you show with the cursor
Yes, sir.
which are the
Yes, sir. I'm
segments?
showing.
She can't. Yes.
Okay. Okay, no problem. You can go to the report and show.
She's using annotation.
No.
Savitri, you are using annotation?
Yes, sir. I use.
She's able to use it. Please
Okay.
explain.
Fine. So what pretext stage you think this tumor is?
This tumor is a pretext 3, sir, with a sparing of only one segment.
With the sparing of?
Only one section of the liver is spared, right
Which
posterior.
one? Which one is spared?
Right posterior.
Okay. So
Right
can you
posterior section.
what are the segments which are spared?
Right posterior segment is spared, sir, and left medial segment is
So if I
little.
am asking you segment means I am asking 1, 2, 3, 4, 5, 6,
Sorry, sir.
7, 8.
Yes, sir. Right posterior segment 6 and 7 are spared, sir.
Okay.
And left medial 2 is appears as
Who is
spade.
separate? So it will be page text 2, 3. What will be the
Yes,
next
sir.
option
Pretext.
for you? What is
The
the next
next we have to
management plan?
next management, sir, had to go according to SIOPL protocol. You need to give a neoadjuvant chemotherapy, sir. It comes under standard risk.
Will you do a biopsy to confirm your lesion, or you have enough evidence to start away chemotherapy right away?
Radiological and biochemical markers are more towards the hepatoblastoma can start.
Can start what?
Neoadjuvant chemotherapy.
Chemotherapy. Very good. Okay. So what chemotherapy you will give for this case?
It's a
Before
standard
giving
risk.
chemotherapy, would you like to do anything else? You showed all the
Yes,
blood
sir.
investigations.
Yes, sir. Before starting neoadjuvant chemotherapy, we would like to go do a 2D echo and do the cardiac evaluation.
Have you done a 2D echocardiac evaluation in this case?
Yes, sir. It has been done. It is
What
normal.
does it show? Normal.
Normal, sir.
But if you see the PT-PTT was deranged, would you be
Yes, sir. PTNR
doing
is.
something for that?
Yes, sir. We have to first correct by giving injection vitamin K, and our patient also has anemia, sir.
Yes,
7
hemoglobin
hemoglobin.
was 7. Yeah.
So, yes, sir. You should
So
need to correct.
you have to build up the patient, isn't it?
Yes, sir. Build up nutritionally and then plan for chemotherapy.
What chemotherapy is planned for this patient?
Cisplatin monotherapy is
Only
according to SIOPL
cisplatin.
protocol. Yes, a standard risk cisplatin monotherapy, sir, according to SIOPL protocol.
Okay, what are the other protocols?
A COG protocol is there, sir, but for pretext 1 and 2, they advise uh, first surgery, then chemotherapy, and for pretext 3, they advise cisplatin with doxorubicin chemotherapy, sir, and 5-fluorouracil for first 4
Yeah.
cycles.
Okay.
And other
So after chemotherapy, if the size is not shrinking, what are the options? And if the size is shrinking, what are the options?
if after chemotherapy, if there is a response, we can plan for the surgical management. If after chemotherapy, if a patient is not responding, there is no response in chemotherapy, we can go for adding doxorubicin and carboplatin.
Supposing this after the chemotherapy, the tumor is localized only to the right lobe. So what are the management protocol?
Hello?
Supposing after chemotherapy, the whole tumor is now confined to the right lobe of the liver. Then what is your option?
Okay. After chemotherapy, if tumor is confined to only right lobe, we can go ahead with right hepatectomy, sir. Right hemiapatectomy.
And do you think this is a good prognosis or a bad prognosis tumor?
With according to the good prognosis, sir, but as AFP is also raised pretext 3 with
Yes.
no other annotations, no
Sometimes if the
metastasis.
alpha fetoprotein is not raised and still you feel it's a hepatoblastoma, it
Yes,
can
sir.
be a
Poor prognosis
hepatoblastoma
and
with a
stage
poor
4.
prognosis.
Poor
And poor.
prognosis, sir.
Sir,
If
time
only
up,
it
sir.
is, okay. So right hepatectomy, if you do, what are the main vessels you will tie? That's the last question I'll ask you.
Right,
What are-
right hepatic vein and middle hepatic vein, sir.
Okay.
And that outflow should take control of IVC and then do the both the
Whether there will be any
infrahepatic.
connection between the IVC and the liver?
Connection. Yes, sir. Connection. I didn't get the questions.
Main veins, you will tie the right hepatic and the middle hepatic vein you told.
Yes,
Will
sir.
there be any venous connection between the IVC and the liver?
Portal vein. Right portal vein will be there, sir. Right branch of the portal vein.
Apart from the portal vein, the portal vein, hepatic artery, hepatic duct, you will be ligating.
Yes, sir.
Anyway, in the hilum area.
Yes, sir.
Behind, between the
Yes, sir.
liver and the IVC, will you have any connection or it will come out straight away?
No, sir. Some small branches will be there and caudate lobe supply will be there.
3 to 4 small branches will be there
Yes,
between
sir.
the
Small
IVC
branches will be there.
and the liver, which you have
And
to
the
be very
branches will be there.
careful while doing a right hepatectomy. Okay.
Yes.
Thank you very much. I think time is up. We could have
Thank you, sir.
discussed more,
Yes.
but you presented well and discussed well also. Over to you, Vikesh.
Next presenter, Shobha, I made
Thank
you
you,
the
sir.
co-host.
Yes. Good morning, sir.
Can you share the screen? Are you able to share the screen?
Who is the next examiner?
Prema, ma'am.
Okay, ma'am is in.
Yeah. Good morning.
Good morning, ma'am.
Morning. I hand over to you, ma'am, for the next proceedings.
Okay, thank you.
Go to slideshow.
Are my slides visible,
Yeah,
sir?
they are visible. Go to slideshow near the animations. Okay, full screen. Yes.
Good morning to all the respected teachers. Today I'll be presenting on left retroperitoneal mass. Patient 2.5 years old male from Fatehpur, informed by mother, came with complaint of lump in left side of abdomen for 2 months. The lump was painless in left flank, which was noticed by mother while bathing the child, has gradually increased from left flank up to umbilicus over this period. There was no history of fever, anorexia, headache, weight loss, irritability, jaundice, trauma, altered bowel patterns, vomiting, hemoptysis, recurrent chest infections, respiratory distress, spontaneous disappearance of lump on micturition, hematuria, abnormal bleeding such as gum bleeding, abnormal eye movement, abnormal discoloration around eyes, bony pains, nodules over the skin, weakness in lower limbs. There was no history of drug intake or febrile illness in mother. Antenatal scans at 20 and 28 weeks were normal. The child was first birth order, full term, normal vaginal, uneventful hospital delivery was present and cried immediately after birth. Past history was not significant. All the developmental milestones were achieved normally. The child was immunized as per schedule, and there was no history of tumor or any other major illness in family. The child was examined in supine position, was active, playful, was of average build, well nourished, weight around 12 kg, height 65 centimeter, pulse was 100 beats per minute, normal in rate, rhythm, volume, and character, blood pressure 100 by 50 millimeters of mercury. There was no evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy. While head to toe examination, there was no evidence of aniridia, opsoclonus, myoclonus, no bony swellings in skull, ribs, spine, or limbs, and no skin nodules. On systemic examination, the central nervous system, chest, cardiovascular system, and musculoskeletal system were within normal limits. On abdominal examination, on inspection, the abdomen was distended, which was more prominent on left side, a well-defined mass of about 11 into 14 centimeter over the left lumbar, hypochondrium, umbilical, left iliac region, which was not moving with respiration was present. Left renal angle fullness was present. There were no scars, pigmentation, or dilated veins over the swelling. Hernial orifices were normal. Genitals genitals were normal with bilaterally descended testes and well-developed scrotum. There were no bony swellings. On palpation, there was no local rise of temperature and it was non-tender. 11 into 14 centimeter firm retroperitoneal left flank mass was present. It had smooth surface, globular shape, extending up to left iliac fossa and left hypochondrium, reaching up to umbilicus, and fingers could be insinuated between the mass and left subcostal margin, and the mass was bimanually palpable. On percussion, mass was dull on percussion without any features of ascites. No broe was heard over the swelling, and normal vowel sounds were heard. Summarizing my case, a 2.5-year-old male child presented with a well-defined, firm, painless, non-tender, bimanually palpable left flank mass for 2 months. Left renal angle was full with no clinical evidence of metastasis. Presenting the differential diagnosis, I have it is a left renal mass, most probably Wilms tumor. The other differential diagnosis could be neuroblastoma, peripheral neuroectodermal tumor, retroperitoneal teratoma, rhabdomyosarcoma. I would like to go with the proceed with the investigations. The hemogram profile was normal. On ultrasonography, large, well-defined, heterogeneously hyperechoic solid mass lesion was noted in left lumbar region.
Dr. Sobha, your examiner is saying something, you should be alert. Okay? Just follow her.
Sorry, sir, I couldn't hear it, sir.
Yeah, you have to look at the examiner also.
Yes.
Pin the examiner at the top on your screen. Okay? Ma'am, please.
Good morning, ma'am.
Ma'am, you are mute. Kindly unmute yourself.
No, it's getting
Yeah, now you are on.
muted on its own. Yeah, okay. So anyway, so please go back to your first slide. Can you go back? Are you able to go
Yes.
back to the first slide?
Yes, ma'am.
Yeah. Okay, the next one, please. The one where you start with your yeah, the next one. Okay, so this mass, it was progressively increasing in size.
Yes,
Can you
ma'am.
hear
It
me?
was gradually progressively increasing in size.
Okay, and you have said that it is painless.
Yes, ma'am.
Okay, so what do you derive from that at this age? I mean, what exactly are you thinking about?
Ma'am,
It's a painless
since
mass
this
on the left side.
Yes, ma'am. Ma'am, since this mass is from the left side of abdomen, most probably from the left flank region, and the while clinical examination, I found out that the renal angle fullness was present and the mass was bimanually palpable. So the mass must be originating from the left kidney. And the age group of this child is 2.5 years, which falls in the age group of Wilms tumor and
So
neuroblastoma as well. But since the
no,
mass
just
is
wait,
painless,
please wait. So let's finish other renal swellings. You don't have to go straight to neuroblastoma. You only have a mass, and there's a history that it is painless, and it is increasing in size. Child is reasonably asymptomatic. But in spite of that, you don't have to go to neuroblastoma, isn't it? So before that, when a left flank mass in a 2.5-year-old child, what else is your differential diagnosis?
ma'am, I'll go with the renal swellings at first.
Yeah, so what are
Left
the other
renal,
renal swellings?
yes, ma'am. Ma'am, left renal swelling, most probably Wilms tumor. It could be hydronephrosis. It could be congenital, it could be mesoblastic nephroma as well. And
No. Wait. So it cannot be mesoblastic nephroma because you have already told us antenatal scans were normal and they'll usually present very quickly in infancy. So you cannot really say that in a 2.5-year-old child. Hydronephrosis, definitely you can, because it can also present painless. You need not have other complaints. Parents may have just noticed it. But antenatal, again, you said there was nothing. So in a way, I mean, if it has been done properly, it would have been detected. Not always, but it would have been, and the child may have presented earlier also. Okay,
yes,
so
ma'am.
please go to the next slide. So don't go for other malignancies immediately. Go to the next
Yes,
slide. Okay. So the typical history is there that mother has noticed it while bathing. So okay, fine, you can think about it. So what is the importance of saying that it has kind of reached up to umbilicus only?
Ma'am, it
What do
shows
you?
that, yes, ma'am, that the lump has not crossed the midline.
Okay, ठीक है. So even hydronephrosis, if they're very large, you can get swelling like that, and sometimes it may appear to have crossed the midline also. It just depends how dilated it is. You can have giant hydronephrosis. So still, we don't know for sure. Your differential is still now between these two. I mean, there are other organs there. But
Yes,
in this age, maybe not. But you can have lot of other, organs are there from which you can have swellings. Um,
yes,
so they can be
yes,
benign. There can be a lot of other benign lesions there. Okay, go to the
yes, ma'am.
next slide. Next slide, please. Okay, so you mentioned a lot of things here. So what exactly are you trying to rule out? What is your main differential which you're trying to rule out by saying all this?
Ma'am, the main differential of my case is neuroblastoma.
Oh,
Uh, since the age group falls in both of them, Wilms tumor and neuroblastoma as well. But since the lump is painless and the child is well preserved, well hydrated, well nourished, so my diagnosis would go more towards left-sided renal mass, most probably Wilms tumor.
okay, so what you always find in neuroblastoma? I mean, they can be asymptomatic, but usually systemic complaints are there. So, like you have
Yes, ma'am.
mentioned, fever, so they're very irritable. Whereas a Wilms who has never had a chemotherapy, at least will let you examine. Once they get chemo, then they cry just like other children. Difficult to examine. So, you have mentioned jaundice also. Is there any significance in this patient?
Yes, ma'am. Metastasis to the liver or compression of the CBD by lymph node.
Okay. And you mentioned bone pain also. Yeah. So there are a lot of systemic things which you're trying to
Yes,
rule out. I think basically you're focusing on neuroblastoma, I think. Hmm. ठीक है. And
yes,
what is the importance of saying there is no weakness in the lower limb?
ma'am. If metastasis to the bone or uh, ma'am, to the pelvis or bone marrow, then there can be paraplegia or weakness in lower limb, inability
Yeah,
to walk.
yeah, I wouldn't say bone marrow here. But
Uh,
apart from metastasis, can a neuroblastoma cause weakness in lower limb in any other way?
Paraspinal neuroblastoma.
Will it present in this way in a huge flank mass? So sometimes you may have
No,
a
ma'am,
large
it will not.
mass, which is, yeah, have you heard of dumbbell tumors?
Yes, ma'am.
Okay. So anyway, we won't go into that now. Go to the next slide, please. Go to the next slide. Okay, so you mentioned antenatal history. Now this child is 2.5 months old. Two
Two
and a
and a
half
half
years old,
years.
sorry.
Yes.
Yeah, 2.5 years. So do you think it has lot of significance here in this particular child?
No, ma'am, it doesn't has a lot of significance, but since in
Okay.
antenatal history we have to take drug intake or febrile illness history, that's why I've
Okay.
mentioned it.
Yeah, fine. So supposing the child was 2 months old instead of 2 years old, then
Yes, ma'am.
what are the tumors which could have been there in the antenatal period also?
Ma'am, congenital mesoblastic nephroma.
Hmm. Any other
Um,
tumor which is known to be there in the antenatal period?
clear. Clear.
What about neuroblastoma?
Yes, ma'am, neuroblastoma could be there.
Yeah. So, I mean, there are many others, but mainly for your case. You've also said about first about the birth order, but let us say the child has no other siblings. But if siblings were there, what is the family history you're interested in? Anything specific?
Ma'am, in family history, any other history of such hydronephrosis or Wilms tumor, neuroblastoma, any other syndromes we have to take, like hemihypertrophy, asymmetrical facies. Um,
Hmm. Okay, hydronephrosis, I didn't really. It's very common. Okay, we will go to
Yes,
the, yeah,
with
that's
Whitworth syndrome.
yeah, okay. We'll go to the next slide, please. Go to the next slide. Okay, next slide. Next slide.
Yes, ma'am.
So there is no loss of weight in this child, and you haven't, told us the blood pressure. So what are the reasons for increase in blood pressure in the various differential diagnoses, which you may tell us later?
Ma'am, first of all, there may be renin-angiotensin system may get activated, or several catecholamines are released, which affect the blood pressure as well.
Okay, okay. So that is for a specific, can you get it even with the hydronephrosis? Just a PUJ obstruction?
Yes, ma'am, we can get it there also.
So there are many things which could have increased the BP, and you haven't told us percentile, for the age. Have you checked that? Have you been able to check that based on the blood pressure? Is it correct for the age? Have you seen that as a centile?
Ma'am, I haven't seen this.
Okay.
From next
Then
time
go
I'll
to the
see.
Yeah, next slide, please. Next slide. Okay, so you're trying to rule out, I think you're focusing a lot on neuroblastoma, I think. You mentioned other things, hemihypertrophy and all that, at another time. Okay. So not much time left. So I think we'll go to the next slide. Go to the next slide. There are one or two things which I thought, yeah. Okay, next slide. We'll leave that. Next slide, please. Next slide. So you said both tests were palpable, but you didn't mention something here.
Yes, ma'am.
So you haven't mentioned about varicocele, which I thought
Yes,
was
ma'am.
missing. And you
Yes,
didn't
ma'am.
say that. Okay, and then you
It
straight
was
away
not visible, ma'am.
Okay, you went straight away to retroperitoneal. But how are you sure it's retroperitoneal?
Ma'am, since the mass is not moving with respiration and it is bimanually palpable, originating from the left kidney. Ma'am, in such age group, 2.5 years age group, in crawling position, it was not possible to do, but knee, elbow, or crawling position we can do and check whether the mass is retroperitoneal or
Yeah,
intra-abdominal.
but we cannot be sure about it being renal. So, okay, next slide, go to the next slide. I wanted percussion, you didn't tell us all the things. Just go to the next slide. Yeah, percussion, you just stopped here. Mass is dull on percussion, but you didn't tell us percussion in the renal angle. So that was
Yes.
missing. Okay, we'll go to the next slide now, quickly, because I seem to have spent a lot of time on this. So go to the next slide. Okay, so I think some things were missing here, but we'll go to the next slide. So how do you want to investigate quickly?
Ma'am, first of all, I'd screen by doing ultrasonography of the whole abdomen and pelvis.
Go ahead.
And then I'll proceed with, along with all the hemograms, I'll proceed with CT, abdomen and pelvis as well.
Okay, I'm not going into details because of lack of time. So you can please read the CT abdomen now.
Yes, ma'am.
Please read it.
Ma'am,
Please
the
read it.
CT scan shows a large heterogeneous mass lesion arising from the lower pole of left kidney, reaching up to collecting system, in which main left renal vein and IVC show maintained post-contrast opacification.
So how are you saying it's arising from the lower pole? Can you go back to that slide? So before that, although you mentioned it, it's important to do the urea creat, because if it is high, then you would rather do an MRI. But
Yes,
anyway, so we don't have time to go into a lot of things. But yeah. So you have said that the renal vein and IVC show post-contrast opacification. Okay. But I can hardly see the upper pole in these cuts. Mostly, I think the whole kidney is involved from what I can see. So is there any calcification in this?
Yes, ma'am, there are calcifications.
You can
Coarse
see it, is it?
calcifications are present.
Okay, it's been reported also. Okay, so
Ma'am, but
okay.
it's yes, ma'am.
Okay, so now what other investigations do you want to do based on whatever protocol is followed by your department? What else do you want to do? So you're looking at the liver, you're looking at the opposite kidney, you're looking at
Yes,
a lot of other things. You should see the chest also. Maybe you should have done a X-ray chest. But
yes,
anyway,
ma'am.
so yeah. So do you believe in doing a biopsy, or do you go ahead with surgery? You seem to have already done the surgery. So
Yes,
what
ma'am.
are your thoughts on biopsy before surgery? Is it required? Is it not required? When would you
Ma'am,
do biopsy in such cases?
in my case, ma'am, it's not required. First of all, I'll go with surgery and then proceed with
So
biopsy and
what are
then
the
chemotherapy.
so what are the age groups in a suspected Wilms where you may do a biopsy?
Ma'am, more than 2 years.
This child is 2.5 years old.
Yes, ma'am.
So do you want to do? So the
No,
extremes of age group where you're not sure, then you would do
yes,
it. It may be lower age. It may be you can get Wilms in infants also, but
yes,
sometimes
ma'am.
you have other differentials where I think the time is up. So quickly, when you do the operation, just tell me uh, how big will your incision be, and what is the vessel which you will tie first, and what should you be careful about when you're operating.
Yes, ma'am. Ma'am, I'll give a transabdominal incision from one flank to the other, and by transperitoneal approach, I'll proceed with the dissection. Uh,
Mhm.
Ma'am, first of all, renal artery will be ligated, and then a renal vein, followed by renal
Okay,
vein.
here we haven't discussed chemotherapy for this patient. Do you want to give chemo in this child? So pre-op.
Ye-
Pre-op.
yes, ma'am. I'll go for chemo since the child is more than of 2 years, so I'll go with chemo as well.
What is the advantage of chemo?
Ma'am, it will downstage the tumor.
Does it help the surgeon?
Ma'am, overall survival will be improved, ma'am. Overall survival of the child will get improved.
How does it help the surgeon?
Is it slow?
Does it help the surgeon in any way?
Um,
It's okay. I think your time is up, but basically it will reduce the vascularity. It can reduce the
yes.
size also. You said one flank to the other. That okay, not really depends on where it ends. But if you have thrombosis in vessels, that may disappear or reduce. It reduces the many risks of surgery. So unless it's stage 1 and a small tumor, you would give chemo. And post-op also you would be continuing the chemotherapy. So
Yes, ma'am.
okay. So I think because of lack of time, maybe we should stop. So thank you very much. You did well.
Thank you, ma'am.
But you should
Thank you,
not
ma'am.
have but you should never have a preconceived idea that it is Wilms and present accordingly. Should think of
Yes, ma'am.
benign conditions also. Yeah. Okay. Thank you.
Thank you,
Thank
ma'am.
you, ma'am.
Thank you.
Next presenter.
Yes, sir.
Uh,
Share my slides.
yeah, please. Yes, we are able to see. Make it full screen.
Can I start, sir?
Arvind sir, are you there?
Yeah.
Oh, okay, Apurva, start.
Okay. Morning, sir. I'll be starting my case presentation. So this was a 3 months, 11 days old female child.
I'm sorry, I was examiner. Please introduce the examiner, Vinay.
Yes, sir. Arvind sir, are you there?
Professor
Sure.
Arvind Sinha, sir. Yeah, sir.
Yeah. Start, Apur.
हमको एक्सरे स्लाइड दे देना बस
Morning, sir. So this was my case is a case of a 3 months, 11 days old female baby. The informants for them were parents and they were reliable. Presented to us with chief complaints of yellowish discoloration of sclera from day 3 of life, pale colored stools from day 3 of life, and dark colored urine from day 7 of life. So the patient was apparently all right until day 3 of life, when parents noticed yellowish discoloration of eyes, which has been persistent since then. It was also associated with passage of clay-colored stools and dark-colored urine. There is history of passive meconium at birth, followed by light yellow-colored stools mixed with clay-colored stools, and the patient has continued to pass clay-colored stools since then. There is no history of blood in stools or vomitus, no history of fever with rash, no history of abnormal body movements or irritability, any history of poor weight gain or refusal to take feeds, no history of abdominal distension or swelling elsewhere in the body, no history of any bleeding manifestations, and no history of any blood transfusion. So, coming to the past history, there's history of trial of phototherapy in the first 2 weeks of life in the NICU of a local hospital, and it was managed conservatively for 15 days. And the patient was then discharged at a bilirubin of 9 as per mother. However, after 1 month since the patient was having persistent yellowish discoloration and there was persistent passive yellow, clay colored stools, the patient was investigated and was referred to us for further management. So the birth history: the child was a term born, born of a non-consanguineous marriage. It was an institutional vaginal delivery, cried immediately after birth, and was birth weight was 2.5 kg. The child passed meconium and urine within few hours of birth, and there is no history of any umbilical catheterization. Into the antenatal history, the mother was para 2, live birth 2. There is no history of abortions, miscarriage, stillbirth, or deaths. There is no history of rashes with fever during pregnancy. Otherwise, antenatal history was uneventful. Mother took IFA supplementation during pregnancy, and antenatal USG was normal. There is no other significant family history, and the child is immunized adequately up to his age. Coming to the general examination, the child is conscious and playful. He is afebrile. His heart rate is 110 per minute regular. Respiratory rate is 26 per minute regular. His blood pressure is 86 by 40 mm Hg in right arm in supine position. The child was having ictus, which was present and involving face, neck, and upper chest and back. There was no pallor, cyanosis, edema, or lymphadenopathy. On anthropometry, the length was 58 centimeter, which was between 58 to 15 centile. The weight was 4 kg, which was less than 5th centile. There were no rashes or pigmentation over the skin. The head examination of head and face were grossly normal. The chest examination of chest, spine was normal, and there were no gross limb defects noted. Coming to the abdominal inspection findings, the abdomen was protuberant. Movement with the respiration was normal. There was no pigmentation, rashes, ecchymosis, scars, dilated veins, visible pulsations, or visible peristalsis. Umbilicus was central, inverted. No swelling or discharge was present. Hernial sites were normal, and there was no swellings noted. Flanks were not full, and genitalia was normal, female. Angle was free, and the anal opening was situated normally, and the appearance was. Yes, sir.
Please go ahead.
Yeah, and the anal opening was placed normally, and the skin was puckered. Coming to the palpation, there was no local rise in temperature. There was no tenderness. The liver was palpable 2 cm below the costal margin in mid-clavicular line. The inferior margin was well defined with a smooth surface and firm in consistency. It was the movement with respiration was present. The spleen was not palpable. Umbilicus was normal. There were no defects or no swelling. The spine was glossy normal. Renal angle, there was no renal angle was normal with no palpable lumps or any tenderness. Genitalia was essentially female type. Anal opening was normal, puckered, and parectal examination was not done. On percussion, liver surface was done on percussion. Liver span was 7 centimeter. The tympanic note over the rest of the abdomen, there was tympanic note over the rest of the abdomen. There was no fluid thrill or shifting dullness. On auscultation, bowel sounds were present and there were no bruit. Rest of the systemic examination was essentially normal.
Okay, so what are your differential diagnosis? So you just summarize your findings and key findings and differential diagnosis.
Okay, so to summarize my findings, so this is a 3 months, 11 days old female baby presenting to us with the yellowish discoloration of eyes and upper chest and back, along with dark colored passage of dark colored urine and clay colored stools, without any history of any history or examination findings suggestive of liver failure, and with examination findings of jaundice and hepatomegaly, without any signs of liver failure. It points towards a case of neonatal cholestatic jaundice. My first differential in such a situation would be this would be extrahepatic biliary atresia. The second differential would be choledochal cyst. My third differential would be inspirated bile duct syndrome. And next in order comes neonatal hepatitis. And there could also be a possibility of a bile duct RMS, rhabdomyosarcoma. And there can be some syndromic conditions such as Alagille syndrome, uh, uh, progressive familial intrahepatic cholestasis, that is PFIC, and some miscellaneous conditions such as hypothyroidism or TBN induced, and sepsis, UTIs, and that's it, sir.
Oh, so I would disagree with your second differential that it is choledochal cyst. Choledochal cyst probably will constitute about 1% of all. So what are the two main groups that you're trying to differential diagnosis that you're keeping?
So one is extrahepatic biliary atresia, and
Yes.
second would be neonatal hepatitis or torch infections or
Neonatal.
yeah.
Yeah, neonatal hepatitis or infective hepatitis. These are the two. So, how do you differentiate clinically whether it is, let's say, biliary atresia or, let's say, neonatal hepatitis?
So the child has jaundice along with clay colored stools and dark colored urine. This is a case of a cholestatic obstructive jaundice, most likely in this age group, and surgical cause of jaundice in infancy would be extrahepatic biliary atresia. On the other hand, in neonatal hepatitis cases, the child would be not be thriving well. The child would be sick. There must be fever, vomiting. There must be abdominal pain would be a primarily more prominent complaint. Um, uh,
Yeah, so you're right. So the neonatal hepatitis patients will be generally sicker, and you may find, let's say, antenatal history suggestive of torch infections and all that in the mother, right? So that's how you distinguish between them, right? So how would you? These are the two main differential diagnoses that you're trying to distinguish, right? So how would you proceed further?
uh, So the child is 3 months, 11 days old. Considering the diagnosis of biliary atresia, I would like to go hand in hand with the rheological investigation and blood investigations, which would involve basically it will apart from the routine investigations like CBC and RFT, we will basically per se biliary atresia is concerned, we'll like to do a LFT, liver function test. In that particularly, we'll be seeing the liver enzymes and the GGT and bilirubin, obviously bilirubin levels, and apart from that, parallelly, I would also get the child investigated for an ultrasound abdomen to look for the findings of biliary atresia.
Right. So let's go to bilirubin level. How do you basically say this is conjugated hyperbilirubinemia based on bilirubin levels?
Uh, so direct bilirubin levels more than 2
Direct hyperbilirubinemia.
direct
Yeah.
bilirubin levels more than 2 milligram per deciliter, or value of direct bilirubin 20% of the total bilirubin is defined as conjugated
Okay.
hyperbilirubin.
Okay. And you talked about GGT. What's the role of GGT?
Uh, Sir, there is bile ductules usually secrete GGT, and since there's proliferation of bile ductules, so GGT is usually raised in case of biliary atresia, and there is a possibility that GGT could be normal, and in that condition, the diagnosis we can think of some other diagnosis also, like
Right. Like,
um, like uh, like PFIC, I guess.
yeah, PFIC. You would need to investigate for PFIC. The GGT generally is low. Okay. Any other new tests which are coming?
So serum MMP7 and lipoprotein X are the new investigations which are coming up,
Right.
and
Okay.
we can straight away go ahead with the intraoperative cholangiogram and further
Okay.
steps in the surgery. Yeah.
Right. So you got the blood investigations and the specific investigation. You wanted to get an ultrasound done, right?
That's
So what findings would you want in ultrasonography, which will tell you the diagnosis, let's say, biliary atresia?
uh, uh, so ultrasound abdomen showing we'll get a fasting and a postprandial ultrasound, and in if first of all, if we don't see a gallbladder, if the gallbladder itself is not visualized, then it becomes a diagnosis of biliary atresia. And apart from that, if it is if it is a distended gallbladder on in fasting, and if there is uh, uh, if there's no contractility, the gallbladder is not contractile in postprandial phase, then it becomes a diagnosis of biliary atresia. Apart from that, we'll see the heterogeneity. The liver is usually more echogenic, and we'll look for ascites. We'll look for splenic malformations, which are sometimes in syndromic association of biliary atresia. One of the very pretty peculiar sign of biliary atresia is a triangular cord sign, which is uh, echogenic shallow region, which is a remnant of fibrosed biliary ducts in the region of porta. So it is a typical finding in a case of biliary atresia. Um, Also, finding of a irregular gallbladder or a absence of an echogenic smooth mucosal lining or a small gallbladder, atretic gallbladder could be a sign of biliary atresia.
So gallbladder anomaly, and you said triangular cord sign, and talked about liver hyperechogenicity. Can you would you want to know something about intrahepatic bile ducts also?
So intrahepatic bile ducts are usually not dilated in case of biliary atresia.
So absence of dilatation is a very important sign that you have to look for. If it is dilated, what would you think of?
Choroidal cyst comes in picture, sir.
Anything else?
Inspissated bile duct syndrome.
Yes. So all the surgical causes. So choroidal cyst, inspissated bile duct syndrome, or let's say RMS, biliary RMS, right? So those are the things which will come to the mind, right? Okay. You talked about splenic malformation. What splenic malformation will you look for?
There are possibilities of polysplenia, asplenia, double spleen, then spleen. These are the findings, sir.
Okay. So if you see other findings are inconclusive, but you see splenic malformation, what would it tell you?
So it points towards a syndromic association of biliary atresia, that is BSM syndrome, that is biliary atresia splenic malformation syndrome, and we would also like to look for other pathologies which are usually associated in a BSM syndrome, that is situs inversus, uh, uh, periodontal portal vein, uh, absent IVC, or continuous azygous vein. Uh, yes, sir.
So if you see any of these findings, your diagnosis of biliary atresia is generally confirmed, right? Okay. So you got lab investigation, you got ultrasonography done. You want to do anything else?
Sir, since the child has already crossed age of 60 days, that is 3 months, is around 100 days. So rather than wasting time, we would like to go ahead with the directly gold standard uh, test, rather surgical, that procedure, that is intraoperative cholangiogram.
Any other algorithms that are commonly available? Just
Sir, we
to
can
diagnose you're opting for intraoperative cholangiogram right away. Any other algorithms that are available?
so we can do a HIDA scan, and
Right.
in that,
Then
yes, sir.
HIDA scan, then go for IOC. Anything else? Any other algorithm is available?
Can go and do an MRCP.
MRCP, and then anything else? Liver biopsy also.
Liver
You
biopsy, yes, sir.
can get liver biopsy and then proceed to intraoperative cholangiogram.
Cholangiogram.
So you've gone to intraoperative cholangiography, right?
Yes, sir.
Okay. So how would you proceed with intraop cholangiography? What do you want to look for?
Sir, in GA under supine position and putting a booster under the right hypochondrium, we'll give a limited subcostal incision, because initially we'll be doing an intraoperative cholangiogram. So after reaching the periodontal cavity, we'll look at the consistency. We'll look at the grossity at the liver, and we'll try to visualize the gallbladder. If the gallbladder is atretic and or atrophic, or there's absent gallbladder, we'll proceed directly with the Kasai Potro enterostomy, as is done in biliary atresia.
Okay. If the gallbladder is distended, now what do you do?
If the gallbladder is distended, sir, we'll like to do an intraoperative cholangiogram by taking a pursing suture over the fundus of the gallbladder, and we'll insert a adequate size feeding tube. And
Would you want to aspirate it before?
yes, sir, we'd like to aspirate, and we'll see whether the aspirating fluid is white colored bile or a golden colored bile. So
what if it is white, what will you do?
So if it is white, we'll straight away go towards SI ostomy.
Okay. Okay. If it is the bile, then you go for IOC.
IOC, sir.
Right. So what do you want to see in IOC?
Uh, in IOC, we'll like to see that the injected dye passes via CBD up to the duodenum, the
Duodenum,
quadrant
anything
duodenum,
else?
and also reaches up to the intrahepatic biliary radicals.
So both duodenum and intrahepatic biliary radicals should be visualized. Okay. So now you're, let's say, going ahead with the portoenterostomy. What kind of portoenterostomy will you do? Modified, extended? Do you know about anything of this?
I know about them, but I don't know what I'll go ahead with. But probably we'll go ahead with the because we want a good bile flow. Our aim is to have a good bile flow. We'll try to go ahead with an extended precise portoenterostomy.
Okay. So what are the limits of extended portoenterostomy?
Sir, on the right side, it is the anterior branch of the right hepatic artery, and on the left side, it is the rex recess. That is the point at which umbilical vein joins the left portal vein.
Okay. Okay. So you've dissected the portal tract. So what will be the depth of dissection? How do you say it is adequate?
The depth of dissection is up to the Glissen's capsule. When we see a translucent lever surface, then we consider that we have
Right.
reached the
Why shouldn't you go inside instead of the liver capsule itself?
possibility of chances of damaging the all patent biliary ductules.
Yeah, they get damaged because of subsequent fibrosis and the results are poorer.
Yes,
Okay.
sir.
Okay. What's the length of rule loop will you take?
Usually 40 to 50 centimeter, and it should be usually customized as per the patient's anatomy.
Okay. So 40 centimeters is standard. People are moving around to less longer, shorter lengths, right? Okay. So you've done the surgery. In the post-operative, how will you manage this patient?
Uh, Post-operatively, we'll keep the child NPO for until the child has proper bowel sounds and has passed platters, and we'll give him IV antibiotics and IV fluids, and uh, we'll start him on cholinergic agent, that is ursodeoxycholic acid, and give him fat soluble vitamins, that is ADEK, and uh, yes, sir.
So cholinetics and fat soluble vitamins. Any other medicines that you want to give?
Steroids can be start because it causes decreased inflammation and increase the bile flow.
Right. Steroids. Any role for antibiotics?
So long term antibiotics are for around 6 weeks to 3 months to 6 months are usually given in case of biliary atresia, IV followed by oral, because there are chances of recurrent cholangitis even if there is proper bile flow, even after classical portoenterostomy.
Okay. Any role for antiviral? When would you think of antivirals?
But if it is a CM, if it is a one of the uh, as per the Davenport classification, there is one of the classification is a CMV associated biliary atresia. So in that situation, if the CMV IgM is positive, we will consider giving ganicyclovir.
Okay. You've given these medicines and you're following up. So how would you define a successful portoenterostomy in the postoperative period?
So bilirubin levels of 2 after 3 months.
So
And
basically, jaundice free after 3 months will be defined as successful portoenterostomy. Okay.
yes,
So you have let's say, have a successful portoenterostomy. Now the patient after 6 months presents with fever and increasing jaundice and clay-colored stools. How will you manage the patient?
uh, initially we'll like to consider that it is an episode of cholangitis. We'll admit the child, give IV fluids, start IV antibiotics, broad spectrum antibiotics, and uh, along with this, we'll get a USG done to rule out any mechanical causes which are probably causing cholangitis. That is something which is obstructing or twisting of the rule loop, and if at all if at all the patient is if at all there is mechanical cause, we like to do a redo, because initially there was a good bile flow. So only if there is a proper bile flow and now the patient has after 6 months is having cholangitis, we like to consider the child for a redo kasai. Otherwise the patient usually have if he has multiple episodes of such cholangitis, we should consider the child for a liver transplantation.
Okay. So you said in the postoperative period, one option is cholangitis and let's say twisted loop, right? Any other causes for, let's say, clay-colored stool and increasing jaundice in the postoperative period?
So anastomotic site stenosis or a like narrowing.
Okay. How would you diagnose that?
By a HIDA scan, sir.
Yeah, you can use the HIDA scan to diagnose it, right? Okay. Anything else you can have?
Twisting, kinking.
You may have bile lakes also, which can cause these kind of problems. Okay, those will need to be drained. Okay, so let's say this child has presented at, let's say, 6 months of age, right? So how would you have proceeded differently?
Like initially you asking, sir, like child
Yeah,
presented for
yeah,
the first time at 6
yeah,
months.
yeah.
The time of the.
Okay, done. You did well, answered most of the questions. Thanks, Sapur.
Thanks.
Thank you, Apurva. Thank you, Arvind sir, for your valuable. Preeti Kumari.
Yes, sir. Sir, I'm presenting with
Can you share the
Shobha's
screen?
laptop. Yes, sir.
Okay. You're presenting with Shobha's laptop.
Yes, sir.
The co-host. Okay. Now you can share the screen. And the examiner is Professor Lakshmi Sundarajan, ma'am.
Yeah, Dr. Lakshmi.
Ma'am, you are there?
Yes, I'm here. Can you hear me?
Dr. Lakshmi. Yes, ma'am.
Okay, please proceed.
Okay. Huh.
Okay, we are able to see. So, over to you, Shobha.
Hello.
Yes, start.
Yeah, we
Good
are able
morning,
to
ma'am.
see the screen.
Good morning, ma'am. I'm presenting a case of left renal cystic mass. A 3-year female, a resident of Bahraich, UP, with low socioeconomic status, came with complaint of swelling over her left side abdomen for 6 months, on and off pain in left side of abdomen for 6 months. History of presenting illness was mass in left lumbar region for 6 months with insidious in onset of initial size 3 into 3 centimeter, progressive, slowly progressive with present size of 6 into 7 centimeter and no aggravating and relieving factor. Pain abdomen was on and off in nature for 6 months. At left lumbar region, there is no aggravating and relieving factors and there is no migration of pain. There is no history of abdominal distension, constipation, loose motion, fever, jaundice, urinary symptoms, weight loss, loss of appetite, failure to thrive, trauma, or anemia. Antenatal scan was within normal limit. There is no history of maternal infection, maternal drug intake, or consanguinity. Perinatal history was the baby was term delivered with lower segment cesarean section with birth order of 2 and birth weight of 2.6 kg. On general examination, patient was active, conscious, hydrated with a pulse rate of 90 beats per minute, respiratory rate 23 per minute, afebrile, and BP was 90/60 mm of Hg. Pyloric teres, cyanosis, clubbing, peripheral lymphadenopathy, edema was absent. On systemic examination, CNS, respiratory system, and CVS are all within normal limit. Weight of 16 kg appropriate for age and height 90 cm appropriate for age. A skin nodule absent, no ecchymosis, nystagmus, opsomyoclonus are all absent. Tongue was normal. Eye no raccoon no sign of Horner syndrome, no heterochromia, no aniridia. Milestones achieved normally as per age. On local examination, inspection, abdomen Fullness present over left side of abdomen. Umbilicus was central and inverted. No scar sinuses, no dilated veins, no visual peristalsis or pulsation seen. The lateral view of the abdomen showing fullness in the left flank. The site of the lump was left lumbar region with size of about 6 into 7 centimeter, globular in shape, smooth surface. Overlying skin was normal. There is movement with respiration absent, pulsation over mass not seen, renal fossa fullness present, and hernial orifice was intact. On palpation, no local rise of temperature seen, no tenderness, mass present in left lumbar region with size 6 into 7 centimeter and extend from mid axillary line laterally to mid clavicular line at the level of umbilicus in transverse plane, superior-inferior extending from 12 to 4 centimeter above the iliac crest. Shape of the mass was globular, surface smooth. Finger can be insinuated between subcostal and swelling. Consistency of the mass was soft, bordered, well-defined, mobility, side-to-side mobility present, movement with respiration absent, plane of swelling was retroperitoneal, pulsation over mass absent, ballotability absent, and bimanually palpable. Hepatomegaly or splenomegaly absent, and no other palpable mass in the abdomen. On percussion, liver dullness start in 6th intercostal space in right mid clavicular line, mass dull on percussion, free fluid in abdomen absent, fluid thrill absent, and renal angle dullness present. Brute or absent, and bowel sounds are normal. Per rectal examination are within normal limit, external genitalia within normal limit. On the basis of history and
Before you
examination.
go for that, can you just summarize the case for me? Summarize it briefly, summarize your history as well as your finding overall.
Ma'am, a patient present, a 3-year female patient presented with left flank mass and pain of abdomen on and off since for 6 months. On examination, patient left fullness present with palpable mass of 6 into 7 centimeter of size, and there is no tenderness. And the flank mass of 6 and the renal fullness present, renal angle fullness present.
Okay. And the mass is bimanually palpable?
Yes, sir. Yes, ma'am. The mass is bimanually palpable. Ballotability was absent.
Okay. Okay, now you can go to the diagnosis. Yeah.
On the basis of history and examination, there is left-sided cystic mass renal in origin, most probably left POJ obstruction.
Why do you call it cystic mass? What is the thing to say it is a cystic mass?
Ma'am, on the basis of consistency.
What consistency makes it cystic? See, and the other thing, an intra-abdominal mass, which you are feeling through the abdominal wall, generally you cannot feel a soft mass. Okay.
Yes, ma'am.
So understand what I'm saying? When a mass is really soft, you will not be able to feel it with nice regular margins and all that. You will not be able to feel it properly. So by the time it has come to being palpable per abdomen, it is no longer soft. And you cannot make out fluctuation in these masses. So it is, I think, difficult for you to call it as a cystic renal mass. Okay?
Yes, ma'am.
You can only say it is a smooth surface mass, right? Which is
Yes,
in
ma'am.
that area. Okay?
Yes, ma'am.
So why do you call it as a renal mass?
Ma'am, because it's the flank mass with renal angle fullness. And
You said it's a
and this is
retroperitoneal
bimanual.
mass. You said
Yes,
it's a
ma'am.
retroperitoneal mass. How do you know it's a retroperitoneal mass?
Ma'am, मैम ये these are not movement, respiration के साथ मैम कोई movement नहीं है.
हाँ जी.
और मैम
नहीं, आप इसको रेट्रोपेरिटोनियल बोलते हैं, तो व्हाट इज अ क्लासिक टेस्ट फॉर अ मास टू बी रेट्रोपेरिटोनियल? व्हाट इज द टेस्ट कॉल्ड? You may not be able to do it for a child, but what is the test called?
knee elbow.
Knee elbow
Ma'am,
position. So you wouldn't have
yes,
done the
ma'am.
knee elbow position for this child. So I
Yes,
think there are a few
yes,
problems with your findings. One, you cannot call it as a soft mass. Second
yes,
thing is
ma'am.
to label it as a retroperitoneal mass based on your clinical findings will be difficult. Okay.
Okay.
All right.
Yes, ma'am.
It's crossing the midline. It's not crossing the midline. You have not mentioned that.
Yes, ma'am. It's not crossing the midline.
Okay. And then the other point in favor of the kidney is you can actually go between the mass and the costal margin. Yeah, you can insinuate your
Yes,
fingers
ma'am.
between the mass.
Yes, ma'am. Yes, ma'am.
In terms of percussion, what is the classical sign said for a renal mass? Percussion sign for a renal mass? You're supposed to be able to percuss a band of resonance, which is the colon going across the kidney. Okay.
Yes, ma'am.
Okay, so there should be a band of resonance. Now, all these things we might not be able to make out in children, but at least you should know the theory of that.
Yes, ma'am.
Yeah, so please go on. Diagnosis.
Left-sided soft mass of renal origin. Then we'll proceed with the investigation. First, blood investigation done.
No. Just tell me what is your DD with that? You have got a differential diagnosis for a renal mass. What is your differential diagnosis?
So, my differential diagnosis was left PUJ obstruction.
Okay.
Then cystic Bill's tumor, cystic nephroma, duplication of colon, pseudopancreatic cyst can be palpable. A
What will
splenic
be the
cyst.
findings? What will be the findings for a pseudopancreatic cyst?
Sorry, ma'am.
It's okay. Go on. So this is your differential diagnosis. So what do you want to do in terms of investigations?
First, ma'am, we'll do ultrasound.
Okay.
Ma'am, first we will proceed with the blood investigation, then an ultrasound to see the mass of origin.
The organ of origin, yeah.
Organ of origin.
And then what else can you see on the ultrasound? What are all the findings you're looking for on the ultrasound for any mass in the abdomen?
Origin of organ, ma'am, is its consistency.
Yeah. So whether it is
Extent,
cystic or solid.
Yeah, yes, ma'am. It's cystic or solid. It's extent extent of the mass.
Okay. Size, shape. Okay.
Size, shape, and
looking for any calcifications within the mass. Okay.
Yes, calcification. Yes, ma'am.
Yeah. So a relationship to surrounding structures, organ of origin, size and shape, consistency, and any calcification. Okay. So you do an ultrasound. You've got the ultrasound for this child?
Yes, ma'am. Can I show one? Ma'am, this was the ultrasound of the child. This shows gross hydronephrosis with thinning of renal parenchyma.
Okay. So how do you know this is a hydronephrosis and not a multicystic kidney?
Ma'am, multicystic kidney में multiple loculated cystic masses होते हैं मैम, और gross hydronephrosis में simple cystic mass.
So अगर hydronephrosis है और calyces are also dilated, that might also look like a lot of cysts, isn't it? So what is the difference between multicystic kidney and hydronephrosis on ultrasound? In terms of the orientation of the cysts?
Location, guys.
So in multicystic kidney, the cysts will be more peripheral, right? Whereas in hydronephrosis, the largest cyst will be in the center.
Yes, medial, in the medial side.
Yeah. Okay. Yeah. Okay. Yeah, the cysts will not be communicating with each other, but sometimes that's difficult to say. Okay. And then what else do you have to see on ultrasound? So you see this gross hydronephrosis on the left kidney. What else do you need to know on the ultrasound? What are the other information you need?
Ma'am, first epidiameter of the pelvic calyceal system.
Yeah. What else do you have to
Then status of parenchyma, corticomedullary differentiation,
Okay.
and ureteric dilatation present or absent.
Yeah, can I request all the other, people who are watching this to stop posting answers on the chat, please? Right? You can always post it after the student has had a chance to answer, all right? But not at the same time. So you want to know about the ureter, okay?
Yes,
And then what else do you want to know? So you want to know about the kidney, you want to know about the ureter, then what else do you want to know?
Bladder wall thickness and
Yeah.
post void volume.
And also you want to know about the other kidney, right?
Yes, ma'am, and other kidney.
Okay, right. So this is a solitary left hydronephrosis. The rest is normal, I guess. Okay.
Yes, ma'am.
Okay. Then, so what do you want to do next based on this?
Diuretic renogram.
Okay. What is the name of the diuretic renogram?
Ma'am, DTPA.
What does DTPA stand for?
Diethyl triamine pentaacetic acid.
Okay. Do you know of any other diuretic renograms?
Yes, ma'am. LL-ECS scan.
Okay.
Which stands for LL ethylene dicysteine.
Okay. And then anything else?
Ma'am, there is one MAC3, but यहाँ मैम वो available नहीं है.
Okay, no problem. Okay, so you've done the DTPA scan, and what are you looking for on that DTPA scan?
Yes, ma'am.
Yeah, tell me, what do you find in the DTPA scan?
Ma'am, in DTPA scan, split function of the left kidney was 25% and right kidney of 75%. Curve.
It's an obstructive curve. When the function is so low, you can't make out the curve. The curve is quite flat, isn't it?
Yes, ma'am.
So the curve wise, you can't get the information whether it is obstructive or not. Okay. When the kidney is poorly functioning, okay, you can't really make out. But what other things you can look for on the DTPA scan? What are the findings you're looking for in this? So one is the differential renal function.
Yes,
then
ma'am.
what else?
Then GFR of the kidney, ma'am.
Okay, GFR is generally not very reliable in this kind of a DTPA scan. Okay, yeah.
And ma'am, T max, T half of T half, ma'am, will see the T half of time.
Yeah. Then you will also actually look at the actual pictures that they give with the scan. Right.
Yes,
just go to the next slide. Subtraction. So if you see in these pictures, the pictures that you will have been given on the left-hand side of your screen is usually only for the first 20 minutes. Right. Is
Yes,
this EC scan, is it? But you will also look at a delayed picture. Okay,
Yes,
there will be
ma'am.
generally a 1 hour post delayed picture, and then you can see if further drainage has happened from that kidney in that time. Okay.
Yes, ma'am.
How do you calculate the differential renal function? So when you look at these pictures, do you know how to actually see whether what numbers they've given you, is it correct or not? How will you look at it? Do you know when the differential function is calculated, at what point of time? So generally the differential renal function should be calculated at about 1.5 minutes, around that time. Okay, so that is before the pelvis is getting all filled up. Okay, so generally around 1 to 1.5 minutes is the time when they should be calculating the differential renal function. Because if you calculate it later on, all the radionuclide will get concentrated within the renal pelvis and it will give you an erroneous reading. All right.
Yes.
So even when you're eyeballing these, you can see what is happening. That in the first, usually these pictures are every 2 minutes. So you can see what is happening by the second picture. What will be you can sort of look at it also and see whether that differential linear function, what number they've given, is it correct or not, right?
Okay.
So you've got this DTPA scan. So based on this, what do you want to do now?
Based on this DTPA result, will plan for the surgery.
You want to go for surgery. What surgery you want to do?
Ma'am, open pyeloplasty.
What is that surgery called?
Anderson Heinrich dismembered pyeloplasty.
What does dismembered mean?
Dismembered means will cut the atretic segment of the ureter and make pelvis attached to the distal ureter.
Okay, so dismember means you are cutting them into two. You dismember it,
yes,
you take it apart and then put it together again. That's what dismembered means, right?
Yes, ma'am.
Okay, along with that, do we need to do anything else along with just a pyeloplasty?
Yes, ma'am. We prefer to do the stenting with the anastomosis.
Okay, what are the types of stenting? What are the methods of doing that?
We can put a DJ stent or IFT or with a nephrostomy tube. Stenting with nephrostomy tube.
Nephrostomy. Stenting with only a nephrostomy tube.
Yes, ma'am.
Okay. Okay. So this kidney was quite big and palpable, right? Suppose the function was not 25%. Suppose this function was 45%, right? So you're doing this DTPA and the function is 45%.
Yes, ma'am.
Now, will you still have to go ahead with surgery for this child?
Ma'am, since the lump kidney is palpable, so we'll consider it for pyeloplasty, or we can wait for another 3 months and repeat the DTPS scan if the function falls more than 10%.
Now, this child is symptomatic, you see.
Yes,
so there is pain. So in this child, even if the function is 45%, we have to go for surgery.
Surgery.
All right.
Yes, ma'am.
So you do the surgery, and then after that, what do you do? When do you take out the stent? And
after 6 weeks, ma'am, after 6 weeks, we remove the stent.
And when will you do follow-up imaging?
Yes, ma'am. After 3 months of operation, we'll do ultrasound KUV, and after 6 months, repeat DTPA scan.
Ma'am, time's up.
All right. Okay. Thank you. Well
Thank
done.
you, ma'am.
I think you presented nicely. Okay. I think the only other thing I would suggest is be careful of the words that you use, as Kanishka has also clearly said. Okay.
Yes, ma'am.
And also about how to say consistency of intra-abdominal lumps, and according to the age of the child, your presentation has to vary, and you should say what is appropriate. Okay. Well done.
Yes, ma'am. Thank you so much, ma'am.
Okay. Thanks.
Thank you, Lakshmi, ma'am.
Sure.
So our next presenter is Dr. D. Murli Manohar, who will be presenting the short case. And our next examiner for today is Dr. Professor Ramesh Babu sir. He'll be overseeing this case.
Please start.
Before you start, the rules are different for short cases. 3 minutes time for presentation, salient points, positive findings, and diagnosis and differential diagnosis. And for examiners, 7 minutes. Thank you.
Yes, sir. Sir, good morning, sir. I'm Dr. Murli Manohar from Neelofar Hospital, Hyderabad, sir. Excuse me. My case is a 2-year-old male child brought by a mother who is a reliable informant with chief complaint of passing urine from under surface of penis since birth, and also with a history of empty right hemiscrotum since birth with a swelling in the right inguinal region since birth, sir. Apart from that, there is no significant history, sir, and the no maternal history intake of drugs. There is no history of consanguinity, and antenatal history is a first-order child with term delivery, normal vaginal delivery with birth weight of 2.5 kg, sir. Child is immunized as per schedule and attained all milestones till date. And the family history is also not significant, sir. There are no similar complaints in the family members. Coming to examination, in general examination, the child is active and playful and there are no dysmorphic faces. The head-to-toe examination is normal. All the vitals are apparently normal, sir. Pulse is 95 beats per minute. Blood pressure is normal 90/50. Respiratory rate is 24 breaths per minute. And anthropometry values are also within the normal limit, sir. Height is 90 centimeters. Weight is 11 kgs. The head circumference is 47 centimeters and mid upper arm circumference is 13 centimeters, sir. And coming to the local examination, the meatus is at the pinoscrotal level and it's wide. The stretch penile length is about 3 centimeters. The urethral plate is poorly developed. There is severe chordae presence, sir. The glans width is about 12 mm with incomplete glans cleft. There is a dorsal hooded prepuce which is inadequate, sir. There is no pinoscrotal transposition or penile torsion. The left testis is palpable in the left hemiscrotum. And the right hemiscrotum is empty with a right testis of about 2 into 1 centimeter, which is soft and it's palpable in the right inguinal region, sir. There is no evidence of any inguinal hernias. And parabdomen exam is soft and the systemic examination is normal, sir. My provisional diagnosis is a 2 years male child with a pinoscrotal hypospadias and a right palpable undescended testis, sir.
Okay, so now let us assume that the right testis is not palpable.
Okay, sir.
Just for the sake of argument, can you
Yes,
tell
sir.
anything else you will come to your mind, or what will be your line of
Since
thinking?
it is a proximal hypospadias with one non-palpable unity, I will think in terms of DSD, sir.
Okay, and what are the possible tests you in your mind? What do you want?
First, I would like to get an screening ultrasound, sir, to check for the status of the gonad, sir.
Okay, what gonad?
Since it is non-palpable, I would like to see if it is testis or any like ovarian structures are present and any presence of any Mullerian structures, sir.
Mullerian structure. Okay, then what else?
After confirming with the ultrasound, I would like to get a karyotyping done, sir.
Right.
So I would like to see what is the karyotype and later, since it's non-palpable, I would like to go for an diagnostic laparoscopy, sir.
Okay. Now, in this kind of situation,
Yes,
where you have one side gonad palpable, the other side gonad non-palpable, what kind of differential diagnosis or actual diagnosis of the patient you are likely to get after your evaluation?
sir, if it is one side palpable and other side non-palpable, it's an asymmetrical descent of gonad, sir. I would like to think of mixed gonadal dysgenesis, sir.
Okay.
Or any over-testicular DSD.
Okay. In this case, let us say that it is palpable. Then also, will you do an evaluation or not evaluation?
I would like to go for evaluation, sir. I would like to do
Why?
it.
So that's what I want to know. What are your indications to evaluate further in a patient with the proximal hypospadias?
I would like to go for a karyotyping if it is a severe proximal hypospadias, regardless of the status of the gonad, sir, or any hypospadias with unilateral or bilateral non-palpable UDT, sir.
So if both gonads are palpable, but it's a proximal hypospadias. Let us say in this case, what you have presented, you said that the right gonad is in the inguinal canal. So both gonads are technically palpable.
Yes, sir.
And it's a pinoscrotal hypospadias. So do you have to evaluate for DST?
So since it is a severe proximal hypospadias, I would like to think of DSD also, sir. Since it might be an unilateral form of over-testicular DSD also might be there, sir.
That's what I'm saying. What are the scores available? Is there any particular scoring system or anything which you have in mind? Applying some points about 3-4 points. What are the factors? Is there any scoring or any grading?
Quigley scoring is there, sir. Or external mascularization score.
What is external mascularization score?
An external mascularization score, we'll see the fusion of the labial scrotal folds, sir. If they are completely fused, you will give a score of 3. If they are not fused, 0, sir. And the presence of micropenis, if no micropenis, the score is 3. And if it is present, score is 0, sir. Then we'll see the location of the meatus, sir. If it is normal.
What score, below what score you need? What is the maximum score?
Sir, maximum score will be
12.
12, 12,
Maximum is
sir.
12 and
Yes,
below
sir.
7,
12.
you have to worry about
Below
it.
7, we have to
Whether you need
evaluate
to
for
evaluate.
PhD, sir.
Okay,
Yes, sir.
let's leave that. So let's come to this patient. So how old is this patient?
2 years, sir.
2 years.
Yes,
So,
sir.
okay. So what do you want to do? I mean, you want to do the testis first or hypospadias first?
Since he is about 2 years, sir, I would like to go for an testis surgery first, sir. Undescended testis, I would like to
Or can
correct.
you combine them?
We can combine them, sir. But since this is severe hypospadias and the urethral plate is also poorly developed, maybe I'll have to go for a two-stage repair of the hypospadias, sir. So maybe cardiac correction.
Do in these patients.
Sir, I didn't get
What
it.
kind of two-stage repairs you plan in this patient? What is the unit experience or your practice?
I would like to go for a Bayer stage repair, sir. Bayer
Okay.
two-stage repair, sir. With
Uh,
so and initially cardiac correction. Later, in the second stage, we can combine the UDT surgery with the urethroplasty, sir, so that we can use the tunica vaginis flap as a urethral coverage, sir.
from which side?
Right side we can use, sir, or both. Left side also is feasible, sir.
So when you do the UDT,
Yes, sir.
you think that the tunica vaginalis still will be there?
The process vaginalis will be there, sir, attached to the testis.
You mean on the undescended testis or the descended testis?
Descended testis, it will be easy, sir. But if it is bilateral, also we can use the tunica vaginalis of the undescended testis, sir.
So I don't know whether that will be so easy as you say,
Yes.
because you know that tunica vaginalis is often like gone during the process of your UDT apex itself.
Okay, sir.
Then it is also short, maybe short in length, and you can have problems when you want to use that from the undescended testis. Anyway,
Okay.
let's not go into that.
Okay, sir.
Now, you said about Cody.
Yes, sir.
So in this patient, what are the components of Cody, and what?
Sir, COD is divided into the four stages, sir. By Devine and Horton. Initially, it's a superficial skin level COD, next fibrous level COD, plate level, urethral plate level COD, and corporal disproportion, sir.
Okay, so in this patient, you tell me the steps of that, how you do that during the first stage. How
Sir,
you
in
correct
first,
it during the first.
yes, sir. In first stage, I would like to initially give a circumcoronal incision and deglove the penis, sir, first. After degloving the penis, I would like to see if the cord is corrected. If not, I would like to access all the fibrotic tissue, sir. Then after excising the fibrotic tissue, if still the cord is persistent, I would like to.
Cord is still persistent?
If the cord is still persistent, I would like to
How
dissect
do you assess that?
I will assess it by the GT metalloline test, sir.
Okay, it is test. Okay, that's fine. And then if it is still there, what do you do next?
Still there, I would like to access all the fibrotic tissue, sir.
Okay, after that also it is there.
After that also, I would like to next divide the urethral plate, sir.
Okay. Okay, fine. So in this patient, let us say that there is a penis scrotal transposition.
Yes, sir.
Will you correct it at this stage or not?
Sir, I would like to correct it after urethroplasty, sir, so that the vascularity to the penile skin will be preserved, sir.
So you mean after the second stage?
Yes, sir. Or during the second stage, we can correct it, sir.
Okay. In this patient, you are not able to catheterize when you start the procedure. Is that possible?
It's possible, sir. Since it's a proximal episode, there is a prostatic cuticle might be present, sir.
So what do you do when such a situation?
With such situation, I would like to give a pressure over the perineum and try to pass the catheter, sir. If it is still not passing, I would like to pass two small catheters, sir. So that
okay, then what else?
Still not passing, I would like to do an SPC, sir.
Sorry?
If it still both catheters are not palpable, I would like to go for an SPC. If there is
you don't want any leave any urethral catheter. Yeah, you have to do cystoscopy or a gateway. Yes, you can leave a catheter. Okay. Thank you. We'll go to the next case.
Okay, sir. Thank you, sir.
Unshare your screen.
Thank you, sir. Thank you, sir, for the thoughtful insight. So our next presenter is Dr. Manish Rajput, and our the next examiner is Dr. Ramesh Babu. Sir.
Please start. Manish, present your case.
Yes, sir. Good morning, sir. Is my screen visible too?
Yeah, go to the local examination.
Okay, sir. Okay, sir.
Okay,
Sir,
yeah.
Sir, I am presenting a case of 3-year-old male child whose local examination is there is distal penile hypospheric meatus with normal caliber having a stretched penile length of 5 cm without chordae with presence of dorsal hooded prepuce having urethral plate width of 6 mm with glans group is adequate of cleft type with glans width of 14 mm and round in shape. Penile median raphe bifurcation seen proximal to mid penile shaft having corpus spongiation pillars visible through not well developed. There was no torsion, there was no rotation, no penoscrotal transposition, and pilator testes were palpable in scrotum, and all hernia sites were normal. There is no hernia present. So this is my local examination.
Can you point out where the meatus is?
Yes, sir. Yes, sir.
Okay. So in such a case, when you are examining either in the clinic or even preferably in the operation theater on the table,
Yes,
what are the points which you have to note on the morphology or whatever the points which will help you decide the procedure?
Sir, we will go for glans group condition. It is cleft, flat, or narrow. Sir, another we will go for glans diameter, glans width, whether it is more than 14 mm or less than 14 mm. Next, we go
In
for
this patient,
condition.
wait, in this patient, this is already 14, right?
Yes, sir. Yes, sir.
This patient, did he have any preoperative hormone stimulation?
No, sir. No, sir.
How old is he?
3-year-old male child, sir.
So, what are your indications for hormonal stimulation, or do you ever use it?
So if there is micropenis, then we go for hormone stimulation. In micropenis, there is size less than 2 cm.
2 or 2.5?
Yes, sir. Yes, sir. 2 to 2.5 cm. Then we go for hormonal stimulation.
Now, this micropenis measurement, is it
Yes,
absolutely good during your in the presence of a severe chordae? When there's a
what,
lot
sir?
of curvature,
Yes, sir.
how accurately can you measure the penile length?
So, criteria for penile measurement. Sir, we will first press the penopubic fat to its lowest level. Then we will stretch the penis up till the.
Who's to decide whether the measurement can you use to see whether you can actually give that preoperative testosterone or not?
So we will go for the amount of chordae in patient through
No, glance
goniometer.
width. You can use the glance width also. Okay.
Yes,
So
sir. Yes, sir. Yes,
let's leave that. In addition to glance width, what else you want to see in deciding the type of procedure?
So type of glans group and condition of urethral plate and its type, its width.
What is the width, ideal width or good width?
So ideal width is urethral plate is more than 8 mm, but in our case it is 6 mm, which is also acceptable.
Okay. In addition to urethral plate width, anything else is important around the meatus or distal proximal to the meatus?
Yes, yes. Is parameter skin is pinchable or mobile or not?
Mobile. What else? Like what about the skin over the urethra?
Sir, is urethral skin is hypoplastic or not?
Okay. Hypoplastic or not? That means how do you know that is the case?
Sir, after inserting IFT through the meatal opening,
You can
if
see
it
the
is
lines. Fine. That's fine.
yes, yes.
Now let us
Yes.
say that this patient, how old is he? Sorry.
A 3-year-old.
3-year-old. So he has not had hormonal stimulation, right?
Yes, sir. Yes, sir. Yes, sir.
Okay. So now, do you normally do hormonal stimulation or not?
Sir, we do normally do not give hormonal stimulation.
Okay.
But if it
Is there
is
any
very
reason why you don't like? Are there any disadvantages of hormonal stimulation?
yes, sir. There is chances of secondary sexual characters or precocious puberty in patient to come early. Or, sir, there may be size of penis, volume of penis can be increased with the hormone stimulation, or vascularity can be increased.
Okay. Now, what about the other abnormalities? What you notice in addition to that skin over that urethra? Anything else you are interested in knowing at the time of on the table? Or now
Sir,
you
there
can
is
say that any other abnormalities there?
sir, there were no genital problems like unintended testes or hernia
No,
sites were
that's
normal.
okay. About the penis itself,
Yes, sir,
somebody
yes,
even
sir.
commented, does he have
Sir, sir, like any torsion is present or not, any penile rotation is present or not, any penis scrotal transpiration is present or not.
hmm. What about the quality of the foreskin? So you need to know
Yes,
that
sir.
also. Some people have very poor foreskin. Some people might have already undergone circumcision or previous
Yes, sir, yes, sir.
procedures where the skin is totally removed. All that you need to know. Okay. So
Yes, sir,
in
yes,
this
sir.
patient, what other factor which will determine the type of the procedure which you are planning to do?
Sir, glans groove IDKC.
Okay. You have mentioned about gland screw. Yeah.
Yes, sir, it
Is
is
the gland
cleft type.
screw good or not here?
Sir, here it is cleft type. It is sir good.
Good only.
Yes, sir.
Okay. So you say that gland groove is good, but the urethral plate is not wide.
Yes, sir, yes, sir, yes, sir.
Okay. Now, what other factor which will help you in decide apart from meatal opening or the skin over the thing? What type of hypospadias is it? Depending upon the location of that meatus?
The distal penile hypospadias.
Okay. So you call it distal penile hypospadias. Now, this position of the meatus, are you always able to say before surgery or on the table only you are able to tell?
Yes, sir. It also depends on the bifurcation of corpus spongiosum and urethral skin present over meatus.
And then
If
what
it is
else?
so if it is more proximal bifurcation of corpus spongiosum, then we call it proximal penile hypospadias.
I'm saying that this patient may actually become a mid-penile or proximal penile hypospadias
Yes,
at some
sir.
point during the surgery. When
Yes,
does
sir.
that happen?
If there is a bifurcation of corpus spongiosum proximal to visible
Leave the
meatal location.
bifurcation part. Leave the bifurcation part. Another
Yes, sir.
factor of that penis, which will make the meatus look distal, but when you correct it, it becomes proximal. What is that?
Sir, it is Cody.
So does he have Cody or severe Cody or mild Cody, or can you tell now or not?
So this patient does not have any Cody. For mild Cody, the angle should be less than 30 degree. For severe Cody, the angle should be greater than 60 degree.
So can you
Sir, your voice is not.
tell whether the Cody is mild or severe now?
So there is no presence of Cody in this patient.
Well, you cannot tell that now. On the table, after degloving, after doing
Yes,
an
sir, yes.
artificial Larsen test only, you are able to tell. Okay, what procedure you will be planning in this patient?
Sir, I'll go for tubulized incised plate urethroplasty or TH2 plate urethroplasty.
Okay, and what is your reasoning for that?
Sir, because urethral plate width is about 6 millimeter and parameter skin is not pinchable and there is a cleft type of glass groove.
Okay, let me say on the table, you find a significant Cody and then
Yes, sir.
curvature.
Yes, sir.
So what are the ways to correct it? More than 30 degrees present.
So
No, let me
firstly,
see first less than 30 degree. Less than the 20-degree Cody is there. How will you correct it? After degloving?
after degloving, first we will do a test, Gitti's test, to know the how much curvature is present. We will look for any urethral plate shortening or fibrosis or any corporal disproportion. If there is presence of corporal disproportion, we will first go for ventral cut on ventral surface known as Perry's cut. Or if it is not correcting the Cody, then we will go for dorsal plication. And it is further not possible to correct the Cody, we will go for the urethral plate mobilization.
Now I'm kind of confused already. Now let us just go a bit slow. I think that time is already over, but I'll just you know tell because we don't have time. After degloving, if the Cody is less than 20, 30 degree, like 20 degree, I will do simple dorsal plication. Okay. What is the dorsal plication? Name of the dorsal plication? Oh, who is frozen? I am frozen or she is frozen? Hello?
She is frozen because of your questions.
Oh, sorry then. Time is up anyway. So yeah, we'll go on to the next case. Thank you.
Thank you, sir. Our next presenter is Dr. Viral Bhatt. Are you there?
I'll share the screen.
Yeah.
Screen visible?
And the next examiner is Professor Kanishka Das sir from AIMS Bhubaneswar. Sir, are you there?
Yes, I am.
Yes.
Is the screen visible?
Okay, sir. Over to you, sir. Yes, sir.
Yes,
Yes, it is
visible.
visible.
Good morning, everyone. I'm Dr. Viral from Grand Medical College, Mumbai. I'm going to present the case of a cystic hygroma in a 15-day-old child. 15-day-old neonate. Parents presented us with a. I tell the case in brief. Presenting symptom with a left-sided neck swelling since birth. Skin color changes over the swelling was present with head tilt, feeding difficulty, breathing difficulty, minimal nasal flaring, and there was a minimal sucking, swallowing, coordination issues was there. There was no history in difficulty in opening mouth or any other swelling was present in the body. No history of recurrent respiratory infection or no history of any other skin lesions were noted. Birth history, maternal actually, the mother was elderly, primary 34 years old, with history of obstructed labor and fetal distress was there, for which LCL delivery was planned. Child was full term, 3.8 kg weight. Vaccination was done at the birth. Prenatally in ANC scan, there was an increased nuclear translucency at 18 weeks, and a large cystic mass was revealed actually at the 32 weeks of pregnancy. But because at that particular point of time, there was no fetal distress, so the pregnancy was delayed up to 37 weeks and the child was delivered in full term. So my provisional diagnosis will be a 15-day-old neonate with a congenital neck swelling, most probably a cervicofacial type of lymphatic malformation. Differential diagnosis can be either cystic hygroma or a congenital cervical teratoma with no major complications currently. General examination, vitals were stable, heart rate was 120, temperature was 97.2 degree Fahrenheit, SpO2 was 99% on room air. Physical examination, child was conscious, alert, active, playful, good cry, no pallor-icterus, edema, cyanosis or clubbing. Head to toe examination was normal. There was no other systemic problem noted in the child. Coming to the local examination, inspection 20 cross 16 centimeter large swelling, tents covering the anterolateral aspect of the neck, extending from the left border of the trachea to the left lateral border of the left sternocleidomastoid muscle, superiorly 3 centimeter above the angle of mandible and inferiorly 1 centimeter below above the supraclavicular region was noted. Appearance the swelling was round in shape. It is not crossing the midline. Bluish hue was noted over the skin with dilated veins noted. On palpation, the swelling is non-tender, freely mobile in the lower aspect. Upper lower borders were palpable, not adhering to the underlying structures. Fingers cannot be insinuated between the mandible and swelling. And other characteristic of this particular swelling in our patient was it is brilliantly transilluminant, fluctuant, non-reducible, non-pulsatile, and there was no brutal thrill. And other examination, there was no oral submucosal axillary or thoracic extension was noted. So my final diagnosis will be a 15-day-old neonate with congenital neck swelling, full-term delivered. Most probably is having cystic hygroma with no major complications. And in this particular case, we proceeded for X-ray neck to look for any tracheal deviation, followed by ultrasound neck, only to look for whether any solid or cystic component was present, followed by which we went for MRI head, neck, and thorax, which mainly gave us the...
Wait, Viral.
Sir,
Yeah.
sir, good morning.
Yes. So respiratory distress, what would you look for as respiratory distress in a newborn?
Sir,
what clinical features?
Sir, respiratory distress means child will be needing any interventional support, sir, either NIV or any ventilatory support, any clinical
No. Clinically, what
Sir, clinically
what
there'll
tells
be,
you that there is respiratory distress?
sir, there'll be chest retractions followed by which there will be increased respiratory rate and nasal flaring will be there, sir.
Okay, color also.
Yes, sir, color. Whether cyanosis is present. In this particular case, sir,
Fine.
cyanosis was absent and there was
So
no chest retraction.
antenatally, there was an antenatal diagnosis here.
Yes, sir.
Okay, so what would they have picked up antenatally? You have seen postnatally how it looks like.
Yes, sir. Sir, antenatal actually only two things can be ruled out. Either there will be increased nuclear translucency. If it is more than 3.5 mm, they'll be ruling out whether any.
Oh, this is such a big neck mass. What nuclear translucency?
Okay, sir.
What other obvious thing they could have picked up
sir,
besides this neck mask?
Sir, whether what type of, I mean, neck mask, what it is, either involving any other deeper extension or not, or whether any it is having any other teratomic component or not. Hello.
What about polyhydramnios?
Yes, sir. Sir, polyhydramnios can be in some patients. Polyhydramnios can be there, sir.
Fine. How it will help you, this antenatal diagnosis?
Sir, antenatal
your
diagnosis.
management.
Yes, sir. Normally, we can even respiratory distress in children, we can rule out, sir, if antenatal diagnosis is there, sir. Because in some fetuses, if respiratory distress is there, sir, in some of the centers, they proceed for exit procedures. If they suspect fetal distress is too much.
Okay. How will it help you? More practical thing. If this child had come to you antenatally, how would it have helped you?
Sir, it will actually, if it is coming more than 20 weeks, the size is too long and there is child development is hampered, sir, then actually we can even proceed for, we can explain the parents regarding the prognosis of the child, sir, in ANC scan. And even Down syndrome, sir, is sometimes associated with cystic hygroma. We can even counsel the parents regarding that particular thing.
Okay, counseling. What is in utero transfer?
Sir, in utero transfer is only done when there is a severe respiratory distress, only if there is a chaos syndrome, or only if there is a either if present.
No, you mistook me. In utero transfer, that is where it helps you. I am giving you a clue. So what is in utero transfer?
Sir, in utero transfer, sir, only when there is a.
No, not intervention.
Sorry, sir.
In utero transfer is simply you counsel them that you will have your delivery in a place where you will teach them and child
delivery,
will
sir,
not.
with a immediate. Yes, sir.
Okay.
Institutional delivery followed by immediate care will be
fine. Good. So in your differential diagnosis, you said cystic hygroma versus lymphatic malformation. So what is the difference? Aren't they the same thing, new and old?
Sir? Pardon, sir?
Aren't they the same things? Lymphatic vascular malformation, cystic hygroma, just old terminology, new terminology.
Yeah. Actually, sir,
so why you put them separately?
No, I just classified it as a cervicofacial type of lymphatic malformation, most probably cystic hygroma.
Oh, I see.
Yes.
Fine. And teratoma you have as a diagnosis.
Yes, sir. Only, sir, because I was about to rule out any respiratory distress or sir.
How will clinical features be different in the teratoma?
Sir, cervical teratoma actually will be mainly presenting with a clinically with severe respiratory distress, and there will be deviation of trachea. Clinically, it can be visible.
Both can deviate the trachea. How will your physical features be different?
Sir, teratoma will also present with some skin. Hello. Sir, can also present with some skin changes or something.
This is also skin changes. Mass consistency, anything?
Sir, mass, sir, on examination, sir, actually be smooth mass will be a teratoma, and only it will be a mixed type of, in cystic hygroma, it can be either mixed or macrocystic, either multiple lobulated mass can be palpable.
So, how will you manage? You've done investigations, you had gone up to investigation, that is why I stopped.
Yes, sir.
Okay, what investigation? How is your investigation helping you to decide management in this child?
Sir, yes, sir. Actually, I would like to mainly differentiate whether it's a macrocystic component, microcystic, or it's a mixed type. If it is a microcystic type of component.
So what did your investigation show?
Sir, for my particular case, actually macrocystic type of component was there. So actually I was initially going for sclerotherapy, followed by which I was planning for surgical excision, sir. Because macrocystic will respond well to sclerotherapy, sir, rather than.
So if it was microcystic, what would you have done? Now that you have found macrocyst, you've chosen bleo. So if it was microcyst, what would you have done?
Sir, if microcystic would be there, sir, then actually mainly some recent things are telling that we can only apply for either some imiquimod trim, some imiquimod creams are available, sir, for these patients.
Practically, what would you do? Microcystic and child is in distress. Such a large mass, microcystic, child
sir,
is
then
in
directly
distress.
surgical debulking will be the option because sclerotherapy is used in microcystic type of thing. Because it is less than 5 mm of cyst and sclerotherapy will be actually not practically possible.
Okay, so surgery, what complications, what problems you are likely to face practically?
Sir,
you are getting the child ready for surgery day after tomorrow.
Yes, sir. Mainly, particularly when I am removing such large mass from the neck, sir, then most probably there will be a neurovascular injury. Most probably in this type of
First, let
swelling.
the child reach the OT table.
Ah,
Tell me
yes,
the practical
yes,
problems before he gets intubated.
sir. Most important thing will be sir difficult intubation, and even if we intubate it somehow and we take the child for OT for such large mass, when we remove the neck mass, the
So
most
what will you be
important.
ready for? What will you be ready for?
Sir, first of all, ventilatory support, sir, the most common.
Before ventilatory support, before you intubate, or as you intubate, what will you be
Sir,
ready for?
actually, sir, bronchoscope also should be there for immediately for.
Okay. Fiber optic, very many places don't have. What will you be ready for?
Then tracheostomy, sir, is the most important thing.
Okay,
We'll be ready for.
right. Fine. So you
Sir,
have, in one of your clinical examination, you say it is freely mobile, superficial part, not fixed to underlying. What do you think with the underlying planes as you operate here?
sir, underlying pain either can be most important is sternocleidomastoid muscle involvement, sir. Sir,
That is superficial. More deeper than that.
sir,
Which
deeper
are the
cervical
planes which
extension
will
if
take
present,
you
then
to?
neurovascular bundle involvement will be there, sir.
Tell me the planes, the neck planes where this will take you to as you dissect. You will get lost if you don't know the
Sir, deep to
planes.
deep cervical fascia it can involve, then directly there will be some injury to facial nerves or it will be
Tell me
involved
the
to.
planes. Again, I'm telling you, tell me the planes. We'll stop with that.
Sir, plane
Tell
can
me
be
the
either, it
planes.
will be either superficial and subcutaneous or followed by which it can go to the deep cervical plane or most importantly directly go into the intramuscular plane, sir. Or last it can directly go to
You
the
are
deep.
still evading the dangerous planes where it can go in.
Yes, sir.
Prevertebral,
Yes, sir.
pretracheal.
Prevertebral, pretracheal, sir. Yes, sir.
Those are the planes that it can go to. So when the examiner gives you clues, take them fast.
Yes, sir.
Okay, so you have operated. Post-operatively, you find this child after ventilation is not coming out of ventilator. Please tell
Okay.
us when our time is up. So what are your fears? What
Sir,
could have happened?
time up, sir, already.
Time is
Over.
Okay, fine. So we'll stop with that.
Okay.
Yes.
Good presentation. You took clues, and but you must speak of common things first.
Yes,
Good
sir.
presentation.
Yes, thank you,
Right.
sir. Thank you so much, sir. I'll stop sharing.
thank you, sir.
Thank you so much.
Our next presenter is Dr. Ashwin Rajkumar, and our examiner is Professor Kanishk Das, sir. Over to you, sir.
Yeah.
Good afternoon, sir.
Viral, you have to unshare so that he will share. Yeah.
Are you able to see?
Answered, sir. Already answered.
Yeah, I can see. Ashwin, go
Thank
ahead.
you, sir. Thank you, sir.
Yes, sir. Good afternoon. Today I'm presenting a case of a 17-day-old female child, informant mother, hailing from Tamil Nadu. Came with complaints of abdominal distension, vomiting, and not passing stools for 2 days duration. So it was a 17-day-old term female who came with who had history of delayed passage of meconium after 72 hours. And ever since then, it's been irregular. Came with abdominal distension, vomiting, and not passed stools for 2 days duration. The vomiting was multiple episodes. Initially was feeds, and later it become bilious in nature. And the baby also had associated refusal of feeds and decreased activity. There was no history of any loose stools or fever associated. Antenatally, it was a non-consanguineous marriage. Antenatal scans were normal. There was no history of any hypothyroidism or gestational diabetes mellitus in the mother. Natal history, it was a full-term normal vaginal delivery, first-order child, birth weight of 2.8 kilos, and had passed stools only after 72 hours on rectal stimulation and suppositories. And the baby was exclusively breastfed. Postnatally, there was no NICU admission and no further follow-up for the same. Coming to the summary, it is a 17-day-old term female child with a history of delayed passage of meconium at birth, presented with abdominal distension, vomiting, and not passing stools for 2 days duration with refusal of feeds and decreased activity.
Yeah, go ahead.
On examination, there was dehydration present and no syndromic facies, but weight of 2.5 kilos. Vitals pulse rate was around 150 per minute. There was no pallidictus cyanosis, clubbing, edema, or lymphadenopathy. On examination, per abdomen examination, on inspection, the abdomen was distended, umbilicus was central, inverted. All quadrants moved equally with respiration, and there was dilated veins, which was prominent all over the abdomen. No scars, sinuses, or any pigmentations were seen. And bilateral hernial offices were free. Anal opening also was present and it was normal in position. On palpation, there was no rise of temperature and no tenderness. Abdomen was soft, liver and spleen was not palpable, and there was no other mass palpable.
Go ahead. Only positive findings. Short case.
Yes, sir. And on per rectal examination, on introduction of a 10 French feeding tube, we were able to go up till 10 centimeters. There was passage of meconium or stools, and there was blast sign positive, sir. That's it. So I'd give my diagnosis of a probable Hirschsprung's disease, sir, with no complications, sir.
Okay, how do you get a history? Why did you say about the history of hypothyroidism in the mother? So that means the child will have these features, is it? If there's a history of hypothyroidism?
So sometimes associated with congenital hypothyroidism can be there.
No, but mother having hypothyroidism will produce congenital hypothyroidism in the child. Or do you wanted a history of mother having hypothyroid stage is
Yes,
on
sir.
antithyroid drugs
On
or
any
something like
antithyroid
that?
drugs, yes, sir.
Yeah, be very clear on that. Mother having hyper U or hypothyroid on drugs or not, and child having that. So be very clear on that correlation.
Okay.
Otherwise, you'll be in the wrong thing. So how in a child in hypothyroidism can you quickly get a clinical feature? What clinical feature will you have when you examine or when you see? Okay, so for you to read later.
Yes,
What
sir.
syndromes were you trying to see when you were examining the child?
Any Down syndrome is most commonly associated with. So
Okay,
any
what else were you trying to see?
Wardenberg-Shaw syndrome, sir.
Okay, fine. Right. Your pigmentation, you are again trying to say something about pigmentation. Pigmentation where?
Any on the back, any cafe au lait spots, any associated neurocristopathy, sir.
Okay, fine. Right. How did you do a blast sign in this child with an infant feeding tube?
Yes, sir.
I thought with a finger we take it out and also the infant we just stick our finger in. So how did you do that? Blast sign.
Actually, it was a neonate, right, sir? We'll not be
Correct.
able to administer
No, but you put a feeding tube in, you said. So how did you
just
see the blast with that feeding tube?
Sir, only just a feeding tube, and then there was a immediate expulsion of stools, sir. So
Okay, when you use a feeding tube, you can use the other end underwater. That's where you'll get the blast. You see. So I wanted to see whether you actually did it. That gives you a good blast, very much like finger withdrawal in an older child. Okay, go ahead. How will you manage this child? What investigations would you plan?
So initially, sir, we had to go ahead with the lab investigations, and the baby was dehydrated, so we had to resuscitate the baby first. And broad spectrum antibiotics have to be started. We have to rule out any septic screening.
You did some imaging.
Yes, sir. We had gone ahead with the X-ray abdomen, which shows dilated bowel loops and also paucity of rectal gas shadow, sir.
Okay, so you thought this was
more likely to be associated with Hirschsprung's disease, sir. So
so
further,
does it look to you like a long segment or a usual type?
so on examination, when we are able to clinically demonstrate the blast sign, so we were thinking more of it.
Okay. On this X-ray?
On the X-ray also, the gas shadow is all the way up till the pelvic brim, sir. So probably
Can you see small bowel or can you see large bowel or can you see both?
we can see both, sir.
Okay, fine. So what do you plan next?
So then we had to go ahead with the barium enema, sir, or water soluble
Contrast enema you want. Okay.
And
are you using barium or using
we use
simple
urographin,
contrast?
sir. Urographin.
Okay. So you did this. What did this show you?
So this also showed classical coning of the transition zone and a proximal dilated bowel loop, and also.
Where is the dilatation?
Sir?
Where is the dilated zone?
So dilated zone is in the. So can you see my pointer, sir?
Yeah, I can see. So you think that is the dilated zone, is it? That somewhere near the mid sigmoid, upper sigmoid?
Yes, sir.
Acha. Or is there a dilated zone further up? In your X-ray, it looks as if
in the X-ray
dilated...
it looks, yes, sir, it's a little bit above. So on.
Yeah. So have you reached the dilated zone or not? Is the question.
In this
Okay.
particular film, we not haven't reached it completely, sir. But on the
Then why did you stop the film? Are you happy with the study, or you should have
we
pushed
should have
in some
continued.
more?
We should have continued. This is not the
Yeah,
classic
because right,
variant. Yes.
right. Okay, so what will you do now? Yeah, 2 minutes left. So what will you do next?
So further, we have to plan for either if the after resuscitation of the baby, if the baby um, uh, is not septic or doesn't have any features of enterocolitis, then we can go for a primary pull through, sir. Transanal
See, what is against doing a primary pull through here? You haven't even got the diagnosis. Where's the question of primary pull through?
Okay,
Your
sir.
transition zone contrast study doesn't even
So
show a
in this
transition
child,
zone properly.
in this child, we can go ahead with a suction biopsy, sir, and where
You do suction biopsies?
in our center we don't do suction biopsies, sir.
Then you tell us what you do in your center, because we want to know what you will do.
So then we would in with the radiological evidence of Hirschsprung, sir. Then we would wait. We'll
Would
see.
you like to repeat this contrast enema properly so that you see the
Yes, sir.
transition zone?
Yes, sir.
Okay, so maybe that is a pliable, plausible answer.
Yes, sir.
Okay, so you would want to know that first. So let
Yes.
us agree with you that there's a transition zone somewhere there in that upper sigmoid where you are showing,
Okay, sir.
or a little more proximal. Let us agree to that. Somewhere in descending colon, let's say there's a transition zone. Yeah, let us agree to that. So then what is your treatment?
So then we would go ahead with we would go ahead with transanal endorectal pull through, sir, primarily.
Acha, is this the right child to go with a transanal endorectal when you have a transition zone in the lower colon, descending colon, or is something else a more classic place to go with the
Otherwise, we
transanal
can
end?
go ahead with the leveling colostomy.
Okay, right. So we'll stop. Time is up. We'll stop with this. So you have done fairly well, but you have missed out on some straightforward facts, particularly transition zone and where you can do a single stage pull through, which is suitable for transanal endorectal. Stick to very, very straight facts. Do not go into controversies. So, like saying transanal endorectal for this higher one. So, don't go into controversies. Stick to very straight facts. Good. Go ahead. We'll finish.
Thank you, sir, for your valuable time and guidance. Our next presenter is Dr. Vidisha Bose, and I feel honored to welcome Dr. Professor J.K. Mahajan, sir, Professor and Head at PGI Chandigarh. Over to you, sir.
Hello, good morning. Am I audible?
Yes, sir.
Yes, sir.
Okay. Please start your presentation.
Good morning, sir.
Good morning.
Good morning, sir.
Good morning.
Yeah. Just a minute, I'll be sharing my slide. Is my screen visible?
No.
Just a minute. Just a minute. I guess there is some issue. Yeah,
Yes.
visible now?
Yes, it is visible.
Good afternoon, respected teachers and all the people who are here for the presentation. I am Dr. Vidisha Bose, SR Academic third year from RIMS Ranchi. I'll be presenting a short case. My patient is Miss ABC, aged 5 months, female, resident of Jamshedpur, Jharkhand. The chief complaint is passage of stool through abnormal opening near vagina since birth. Source of history was mother, who is educated till higher secondary and reliable. The current history is she has been passing stools from an abnormal opening near vagina since birth. There is no history of abdominal distension, urinary tract infections or cyanotic spells, respiratory distress, limb abnormalities, or swelling on the back. Am I audible?
Yes, please continue.
Yes. Thank you, sir. In the antenatal history, mother is aged 24 years. The child is a result of spontaneous conception from a non-consanguineous marriage. She went for regular antenatal visits. There is no history of usage of drugs or fever during pregnancy. Antenatal scans were normal. And the child is the second child of the couple on a term institutional delivery via normal vaginal birth, 3 kg at birth. The child cried immediately after birth, passed urine and stool within 24 hours of birth, and immunization and developmental milestones were complete as per age. There is no similar history of similar congenital anomalies or other genetic disorders in the first, second, or third degree relatives of both the maternal and paternal sides. The patient is on regular dilatation since birth, and there is no history of previous surgeries. Moving to the clinical examination, the baby is alert, active, and playful, weighing 6 kgs, that is 22nd percentile as per age, and 63 centimeters in length, 34th percentile as per age. The baby was afebrile during examination. Pulse was 98 per minute. BP was 90 by 50 mm of mercury. There is no pallor, cyanosis, jaundice, clubbing, pedal edema, or generalized lymphadenopathy. Head-to-toe examination was essentially normal. Coming to the local examination of the perineum, the child's genitalia appears to be normal. Gluteal folds are well developed. Natal clefts were normal. Anal dimple was not seen. Opening was seen within the vestibule, lined by the vestibular mucosa on all the 4 sides. There were 3 orifices in the perineum. Anal opening was placed anteriorly inside the vestibule, the patent, and we were able to pass a dilator of size 4 into it. Hager's dilator was passed, and probing of urethral and vaginal openings was normal. On the systemic examination, moving to the abdomen, on inspection, the abdomen was flat, umbilicus was inverted, normal in position. There were no scars, sinuses, or dilated veins were seen. Hernial orifices were intact. On palpation, the abdomen was soft, non-tender, and no palpable masses were felt. And on percussion, it was essentially normal. Liver dullness started at 6th intercostal space, and span was 10 centimeter. In moving to the other systems, in cardiovascular system, S1, S2 was heard with no associated murmurs. Respiratory system, the bilateral air entry was equal with no added sounds. All the limbs, upper and lower limbs, were essentially normal, and there were no spinal defects on examination. The spine was also normal. So moving to the summary, my patient, a 5-month-old female, came with chief complaints of passage of stool through abnormal opening near vagina since birth with no other associated complaints. On examination, the stool was seen coming out from an opening just posterior to the vagina within the vestibule, lined by the mucosa on all sides with well-developed gluteal folds and normal urethral and vaginal openings on probing. Systemic and general examination were essentially normal.
So, yes, what is your diagnosis?
I would like to place my provisional diagnosis as a low anorectal malformation in a female with vestibular fistula with no other obvious associated anomalies.
So, in a short case, in examination, generally you are asked to present everything in a summarized fashion. And at the end, you are asked to give your diagnosis, summarize the case and diagnosis. So its presentation is different from a long case. So why do you say that it is vestibular fistula?
So because on the
Dr. Preeti, please mute yourself.
I have muted her, sir.
Vinay Shelke also can mute. Yes. So why do you say it is vestibular fistula?
Taking cues mostly from the clinical examination, we can see that there are 3 openings in the perineum, and the 3rd opening from which the stool was seen coming out was seen within the vestibule, lined by the vestibular mucosa from all the sides. So my diagnosis would point towards vestibular fistula itself.
So, okay, if there were 2 openings in the perineum, what would be your diagnosis?
So in case of 2 openings in the perineum, we can think of 2 things. One is urogenital sinus and one is rectovaginal fistula. But rectovaginal fistula is a kind of rarity. So
if it's a urogenital sinus, then is it likely that a 5-month-old child will present without anal orifice and urogenital sinus is there? Is it a common occurrence, urogenital sinus with a fistula?
No, sir, it's not a common occurrence. We have not seen.
Yeah. So what other associated anomalies you would be looking for?
So in any case of ARM, we generally try to rule out all the vectoral anomalies, that is vertebral anomalies and anorectal malformation, tracheoesophageal fistula, cardiac anomalies, renal anomalies, and limb defects.
So without any investigations, you have said that there is no obvious associated anomaly.
So investigations, it's in the next slide. We will investigate accordingly. We will be doing X-ray LS spine to rule out the spinal anomalies. We will be doing USG KUB to rule out any renal anomalies if it is associated, and we will do a 2D echo to rule out the cardiac anomalies. And
Okay, so what investigations you will do? Just tell the investigations.
so can I place the slide? Actually, I prepared
Yeah.
a slide with that as well.
Okay.
So in the management plan, first of all, we have to go for the pre-op preparations. Since the child is already on fistula dilatations, we will before taking any operative interventions, we will be going for routine blood investigations, X-ray LS spine to rule out the sacral defects or sacral and if any other anomalies are present, and 2D echo to rule out the cardiac defects, USG KUB for renal association or renal anomalies, and lower GI dye study is sometimes done to see the caliber of the fistula or how much dilatation has been achieved, whether any dilatation in the colon is also present, so that we can take decision accordingly. Because if it's hugely dilated, we should be first attempting for decompression of the bowel via colostomy.
So routine blood investigations, okay. X-ray lumbosacral spine, fine. Then 2D echo, ultrasound. Lower GI study, are there any specific indications for doing lower GI study? Or in every case, you will do lower GI study?
If we are planning to do primary procedures like primary pull-through procedures like PSARP or primary ASARP, we are attempting, having a lower GI dye study will be helpful for knowing that whether the post-op whether there will be any other post-op complications or not.
So in this particular case, what will you do? You will do lower GI study or you will not do lower GI study?
So I would like to proceed with a lower GI study to look at the
Why would you do that?
To
You
take
talk about this case. You talk about this, the case given to you. So you talk about this case.
So can I shift back to the picture where I showed the local examination of the perineum?
Yes, please.
So here, as we can see, and there is and the fistular caliber, as we can see here, it's according to the anal normal anal diameter that is present according to the age. For this patient, it was appropriate for the age. So not doing a lower GI dye study will also be like supportive. But if it is less than according to the if it is less than the required amount for the age, then we can do a lower GI dye study to understand whether the
Can you tell one condition in which your doing lower GI study will be justified?
If there is anal steno.
Because we have been given only 10 minutes, so you quickly answer. Now the treatment and other parts are still pending. Yes. So pouch colon. Have you heard of pouch colon associated with anovestibular fistula?
Yes, sir. Pouch colon.
Will be the presentation of pouch colon with anovestibular fistula?
So we can find receded genitalia is also seen in pouch colon.
So more common clinical presentation, abdominal examination, what will happen?
Abdomen will be like it will be distended. It will be hugely.
So distended abdomen in the beginning itself.
Yes, sir.
You should suspect pouch colon. So if pouch colon is associated, then it may be justified. Every case you will do dilatation of the fistula, or in some cases you will do it.
So in our institute, we generally proceed with the dilatation of the fistula when the baby presents in the neonatal period. Then the parents are
Now
adequately.
you proceed further. What will you do in this case?
In this case, the patient actually presented in the neonatal period first. So we had counseled the patient that we should be going with the dilatation first. We used in the first month, we told the patient to be placed with the Hegar's dilator number 4. Then it was gradually increased till the 5th month. And since the patient finally reached the dilatation level up to Hegar's dilator 12, then we took up the patient for primary PSARP.
Primary PSARP already done in this patient.
Yeah, it just got completed last week.
Okay. So you have done primary PSARP. What are the objections for doing primary PSARP?
Time up, sir.
Okay, quickly.
So in case of primary PSARP, there is a prolonged NPO period required. Expertise is required on the part of the surgeon. And if
danger is breakdown. So
yeah,
what
suture
other
breakdown is
method?
Yes, sir.
Breakdown of repair is
Yes.
danger if your bowel is not prepared properly.
Yes, sir.
So what other method you can use?
So other methods, we can use ASARP, anterior sagittal anorectoplasty. We can use limited PSARP where the levator is not divided, and we can do mini PSARP when the extension
And you can do it without colostomy, and you can do it with without colostomy like you have done, or you can do it with colostomy in some cases. Where
Yes.
does it fit into? Are you aware of Crick-and-Buck classification?
Yes, sir. It is generally divided into 2 parts: major clinical groups and minor clinical groups. Major clinical.
Where does your case fit into?
So it is a major clinical group, vestibular fistula.
Okay. Okay, we can go ahead to next case.
Thank you so much, sir.
Thank you, sir.
Thank you.
Thank you, ma'am. Our next presenter is Dr. J. Madhuri, and our examiner will be Dr. J.K. Mahajan, sir. Over to you, sir. Dr. J. Madhuri.
Good morning, ma'am. Can you hear me? Good morning, sir.
Good morning. Yes. Present your case. You can actually put up the picture and summarize. How many slides? 11 slides. Okay, quickly. 2-3 minutes for presentation. Make it a slideshow. Yes, start. What is the issue?
Dr. J. Madhuri, please
you're not
unmute
audible.
yourself, ma'am. She hasn't unmuted herself. And I am asking her to, but she isn't responding.
Madhuri, please unmute yourself.
Hello.
Yeah, you are audible now.
Am I audible now, sir?
Yeah.
Can I proceed, sir?
Yes.
Yes, ma'am.
Thank you. A 48 hours old neonate, information from a reliable informant mother came with a chief complaint of lower abdominal wall defect with a raw area. There is a continuous dribbling of urine from that raw area, and there is a right inguinal swelling since birth. Mother has taken foliate supplements. There is a spontaneous consumption, no OCP usage, no fever, or no polyhydramnios. It's a booked and immunized case, and the anomaly scan was normal. The birth order is 1 and the maternal age is 18 years. It is a single term lower segment cesarean section due to non-progression of labor with a birth weight of 2.5 kg. Postnatal history: cried immediately after birth, passed meconium in 24 hours. Third degree consanguineous marriage, baby was immunized on day 1. The family history is not significant. General examination: the baby is active, alert, and playful neonate. Vitals: pulse rate 120 per minute, respiratory rate 35 per minute, anthropometry 75 percentile. Head to examination, no dysmorphism, polydactyly, extra little toe of both lower limbs. Coming to inspection, the abdomen is protuberant. It is a locet umbilicus. There is a raw area in infraumbilical area corresponding to urinary bladder. The size is 3 into 3.5 centimeter and it is globular in shape. The bladder mucosa is pink and smooth with no polyps, which is bulging on crying. There are 2 ureteric orifices which are expelling urine. Coming to urethral plate, it is extending from base of the bladder to glans, which is dorsally open. The width is 1 centimeter and verumontanum is seen. The phallus is short and broad. There is a dorsal chordae and ventral prepuce. The glans is flat and everted. Scrotum: the right side of the scrotum looks empty with a swelling in the right inguinal region, which is getting prominent on crying. There is a left testicular impression which is present, and anteriorly placed ectopic anus, and the limbs are externally rotated. On palpation, there is a 3 into 4 centimeter triangular facial defect with intersymphyseal distance 2 centimeter, divarication felt around the defect, bladder plate pliable admitting thumb. The stretched phallic length is 2.5 centimeter. There is a divergent corporal tissue. The right testis is in the inguinal area. Left testis is in the hemiscrotum. Rectal examination admitting little finger. Limb and spine are normal except polydactyly, and the renal angles are free.
So, for rectal examination, is it really required in this patient?
Sir, actually, in this cases, we see for any there is anal stenosis and all, sir, association malformation. So we'll look for
uncommon, very uncommon. So,
yes.
rectal in abdominal case, okay, but sometimes it may not be necessary. Very uncommon. Okay, go ahead.
Coming to summary of my case, it is an antenatally undiagnosed 48 hours old 2.5 kg male neonate. It's a case of classical bladder extrophy with epispadias complex, pliable bladder plate with a right palpable undescended testis and right reducible indirect inguinal hernia and bilateral polydactyly of both lower limbs. No other associated anomalies.
So what will you do? Okay, you've written your diagnosis, bladder extrophy, right undescended testis and inguinal hernia. What next now?
Sir, first of all, we'll investigate and manage, sir. First of all, we'll counsel the parents regarding the stage procedures or single stage, whatever stage we are proceeding with, and we tell them about the bladder care, and then we further proceed with management, sir.
So what will you do? You will do single stage or you will do staged repair?
So we go with the stage repair, sir.
So you have seen and you are comfortable with staged repair?
Yes, sir.
So stage repair, what steps are there?
Stage repair, first 3 to 6 months, we go with bladder extrophy repair, sir. Bladder repair.
You have any more slides or no? More slides or?
Management. First, we'll go with investigations, sir. First, baseline investigations.
Okay.
X-ray has to be taken in the beginning to assess for the pubic diastasis, sir. And ultrasound KUB has to be done to know the status of the kidney, ureters, and the bladder also. and spinal ultrasound of the spine to look for any spinal anomalies. Routine blood investigations before the surgery has to be done.
So, in a case of classical bladder extrophy, anomalies are common or uncommon?
Relatively uncommon, sir.
Okay.
Compared.
Okay, go to next step. What will you do?
Sir, we go with staged repair, sir.
Stage repair, okay.
Yes, sir.
So what is first stage?
First stage is planned in 3 to 6 months, sir, where there is a bladder repair along with posterior urethra repair, abdominoplasty and umbilicoplasty. In my case, hernia is also there. Herniotomy is done.
Sure.
And UDT is also treated, sir.
So UDT is also treated. What are the steps of first stage repair? What is important?
First, after assessing the baby with the X-ray and spinal ultrasound, sir, preoperatively we have to go with the care of the bladder, sir. To prevent from the dryness, the continuous saline irrigations has to be kept and dressings has to be kept to prevent the dryness of the bladder before planning. And then after doing investigations and all, we proceed with the surgery.
Okay. So you will maintain bladder first 3 to months, prevent irritation of bladder, dryness.
Yes, sir.
Bladder, and then proceed with surgery. So what quickly tell what steps you will do?
First one is bladder repair, sir. Steps of the surgery, sir.
Yeah.
Incision is made starting from the umbilicus around the bladder, and it is extended up to the posterior urethra, up to the verumentanum, and incision is deepened. So before that, we have to catheterize both the ureters with the 5 French feeding tubes, so that the location of the ureters are properly located, are properly traced out. The incision which was made was deepened, and the bladder plate is separated from the rectus muscles.
What is the extent of mobilization of bladder plate?
Up to verumentanum, sir. Distally up to verumentanum.
And inside?
Inside up to lateral wall.
Lateral wall where? Obliterated? Yeah, have you heard of obliterated umbilical ligaments?
Yes, sir.
So what is important step in this repair? What is important step in this repair? During turning of bladder, what will you try to do? What is affecting continence in the children?
Intersymphyseal ligament has to be divided.
So posterior placement of bladder
And posterior urethra
into the
pelvis has to be done.
So you will divide intersymphyseal ligament and do what? And wrap it
and place the bladder base and the posterior urethra deep into the pelvis.
And wrap this ligament around
yes, sir.
Around your repair.
Posterior urethra.
It is supposed to give some kind of continence or some resistance to outlet. Because
yes,
once you have closed this, what do you expect? You expect that bladder will grow.
Grow, yes, sir.
Okay. So what is second stage now, and when will you do it?
Second stage is planned after 1 to 1.5 years, sir.
Okay. So what will you do?
Cantwell-Ransley repair is done,
What
sir.
is Cantwell-Ransley repair?
It's a type of epispadias repair, sir.
What is like quickly in summary tell what is Cantwell-Ransley? Epispadias repair, fine, but what do you do in this?
Sir, here reverse of MACP is done, sir, where a glans is cut longitudinally and it is repaired and it is closed transversely, and mobilization of the urethral plate is done.
So you mobilize three elements of
Yes, sir.
the penis, that is urethra separately, one corpora separate, another corpora separate.
Yes, sir.
And you will tubularize the
Yes,
plate
sir.
and try to
Tubular.
put it
Ventrally, sir.
ventrally. How is it different from any other repair you know of?
But,
Mitchell repair?
Mitchell, yes, sir. Mitchell
So how
repair.
is it different from Mitchell's? Okay.
Time up, sir.
Yeah, time up. You read about Mitchell's repair.
Okay,
So
sir.
when will you do bladder neck reconstruction?
It's around 3 to 4 years, sir, where the child is for trained for bladder training and able to micturate, sir.
So you have written prerequisites toilet trained. Do you expect these patients to be toilet trained?
Like before the bladder neck reconstruction to happen, these are prerequisites, sir. Like bladder capacity should be minimum of 65 ml, and the child is about to be toilet trained.
Toilet training is a problem in these patients. You don't
Yes, sir.
expect a child to be toilet trained with just turning off bladder and Cantwell-Ransley repair.
Yes, sir.
Only you expect that bladder volume will grow, then you can do bladder neck reconstruction so that there is no increased pressure and upper tract damage.
Sir.
Okay. So then what next?
Then we go with bladder neck reconstruction, sir, at 3 to 4 years of age.
Yeah. So bladder neck reconstruction, after bladder neck reconstruction, what will happen? So what percentage of patients are likely to gain some continence, or what type of continence it will be?
Continent.
Are they likely to become continent or not likely to become
Yes, sir, likely to become continent, sir.
What percentage of patients become continent?
60%.
Will become continent. Is it like continence without assistance, or they need some assistance?
Any augmentation, catheterization, and also CIC.
Yeah, so extrophy is a complex topic, and it's a big topic also. In 10 minutes, probably it's not able to discuss, it's not possible to discuss everything. So bladder neck reconstruction, you expect that bladder will grow, and you will give them some time, and then some of them may become continent with CIC, or then there may be resistance to do CIC. What next you will do? Patient, you have done the 3 surgeries, 6 to 7 years, patient is still leaking and it comes back to you. What options? Quickly, just tell the name.
Sir, we go with bladder augmentation, sir. Continent.
With or without?
Sir, bladder augmentation, sir.
With Mitrofenov.
Mitrofenov, sir. Yes, sir.
And bladder neck closure. So it's indicating time is up. So I will stop here.
Okay, sir. Thank you, sir.
Thank you.
Thank you, ma'am. Thank you once again, sir, for your valuable time and guidance. Our next presenter is Dr. Shaurya Katiyar, and our examiner is Dr. Professor Anand Aladi, sir, Professor and Head Department of Pediatric Surgery, Bangalore Medical College. Thank you, sir. Over to you, sir.
Good afternoon. Are you ready with the presentation? If so, you can straight away start.
Yes, sir. Yes, sir. So I'm not able to share. 1 minute, sir.
You can start now.
A very good afternoon, sir. Sir, I'll be presenting a case of it is not moving.
You're not audible. Is it only for me or?
Sir.
Shaurya, you can start. I'm having the control because you're unable to share the screen.
Okay. We'll start. Next slide. Okay.
So, Shaurya, you are not audible.
You
Sorry,
from
internet connection is weak.
after birth, he was not
Shaurya,
able
if
to
your
pass.
internet is
He
having a
was
problem, you
outside
can put off your
hospital.
video.
Yeah, 1 minute, sir. Am I audible, sir?
Yeah, you're audible now.
So I'll be presenting a 12 days male child who presented in our emergency, sir, with the complaints of not able to pass urine and respiratory distress. And he was admitted in a outside hospital where he was catheterized at day 3 of life. And there was history of intolerance to feed also, sir. There's no history of any fever, vomiting, diarrhea, or abdominal distension. In antenatal scan, history of oligohydramnios in last trimester, though the documents were not available. So he was on examination. He was a sick-looking neonate with symptoms of dehydration, tachypnea, tachycardia, and intercostal and subcostal retractions were present. Per abdomen examination showed protuberant abdomen with everted umbilicus, no dilated veins or lump, no suprapubic fullness was visible. It was soft on palpation with no organomegaly. The external genitalia was normal with intact hernial orifices with a 6 French Foley's catheter in situ. On investigation, the initial investigation, the total leukocyte count was raised, the platelets were low. The urea creatinine at that time at the time of admission was 179 and creatinine of 4.64. Blood gas also shows metabolic acidosis with pH 7.25 and bicarbonate of 14, sir. After adequate resuscitation, we moved to the investigation in which USG ultrasound KUB of the patient was done, in which there was posterior urethra dilatation of up to 5 mm, suggestive of posterior urethral wall, along with bilateral moderate hydrouretronephrosis with bilateral renal cortical equitexture increased CMD, and the CMD was lost, and there was cystitis. Next slide. Then we proceeded with the MCUG, sir. The expected bladder capacity was 24.5 ml. In the filling phase, there was irregular bladder outline, small capacity bladder, only 16 ml with no diverticula, bilateral VUR, right side grade 2, left side grade 5. VUR first noted on left side at only 5 ml bladder capacity. In maturation phase, a dilated posterior urethra with abrupt narrowing noted at proximal urethra and posterior urethral diameter of 5.5 mm. Diagnosis: posterior urethral wall with bilateral vesico-ureteric reflux with bilateral CMD loss. In initial, at the time of initial management in neonatal management, adequate fluid and electrolyte correction was done. A respiratory support in the form of oxygen was provided, and once the child was stable, he was taken up for left loop ureterostomy, sir.
You're done with the presentation?
Actually, Shaurya, I'm sorry, Dr. Aladi, I'm intervening here. Your case was given as a case of ureterostomy. So it lacked all all the examination and all those features which are important. So you just finished off with the history, treatment history.
Do you have a clinical picture of the patient at least where you can discuss? Because you presented and it is like summarizing what you do in the rounds, ward rounds, what you have done.
Sir, I'll summarize, sir, as a 12-day-old male child who presented in emergency with the complaints of non-passage of urine and antenatally diagnosed. Antenatally, he was diagnosed as oligohydramnios. The mother was diagnosed as oligohydramnios. Then we proceeded with neonatal resuscitation, and after adequate investigation, he was diagnosed as a case of PUV with the bilateral VUR, for which we proceeded with left ureterostomy, sir.
No, do you have a picture of the, because like Dr. Vikas said, your case was a status post-ureterostomy. So when you're doing examination findings, you would be expected to talk about all the findings on the abdomen after the ureterostomy has been done.
Sorry, sir, I don't have that picture, sir.
No, but in your description, you have seen the patient, right?
Yeah, sir, I have seen.
So what can you describe? What is the abdominal findings post-ureterostomy?
Sir, currently a loop stoma is seen in left lumbar region, which is draining urine, which is draining loop ureterostomy with loop stoma, which is draining urine, sir.
Is it draining urine from both the openings?
The proximal, the above opening, it is draining.
And nothing draining from?
Sir, proximal more than distal, sir. It is draining from distal also, but proximal more than distal, sir.
Okay.
With slight peristomal excoriation is present, sir.
And your presentation, going by presentation, this child came to you in the neonatal period with a sick-looking child,
yes,
with
sir,
all deranged electrolyte, blood gas, and RFT.
Yes, sir.
So what would you have done in the first phase? You said neonatal resuscitation, that's fine. What would you have done with these findings? Your diagnosis, you said in your summary, was an obstructive uropathy.
Yes, sir.
With antenatal diagnosis and changes secondary to that in the kidneys.
Yes, sir.
Okay, so what would you have done?
Sir, so proceeding first with the initial resuscitation part, then going further an ultrasound, an ultrasound for both the kidneys and ureter as well as the bladder to know the current situation of those. And then once the child was stabilized and adequate antibiotic prophylaxis was given, we proceeded with MCUG, sir, to rule out.
So before the MCU, when the child has come to you sick with a creatinine of 4.6, metabolic acidosis, and you also had an electrolyte abnormality which is atypical. Can you tell me what was that atypical finding?
Sir, according to there should be hyperkalemia, but in this the potassium was slightly on the lower side, being 3.2, sir.
Okay. So with this findings, so what would you have done first? When you already have you had this child had a Foley's catheter 6 in C2, and this was the blood investigations after how many days of catheterization?
Sir, almost 9 days of Foley's catheterization, sir.
And was the Foley's catheter draining adequately every day?
Yes, sir. Sir, on history, the mother told that it is draining, sir. And we also saw after admission that it was draining well, sir.
Okay. So this is the investigation after almost a week of catheterization.
Catheterization, yes, sir.
Okay. So what would you do next? You said you will do an MCU after making sure the urine investigation was normal.
Yes, sir.
And the MCU findings was what you had put up.
Yes, sir.
Okay. And with this MCU findings, what would be the next step of management? And when you said you resuscitated the child,
yes,
the fluid and electrolyte, what was the best investigation findings you got with respect to biochemistry?
Yes, sir. Sir, with respect to biochemistry, coming to urea and creatinine, the best urea and creatinine that we could achieve in the admission was of 2.95, sir. It didn't go below 2.95. We waited for at least 6 days more with adequate fluid resuscitation and antibiotic prophylaxis. The metabolic acidosis part had improved. The pH had come to 7.34 and bicarbonate had also come to 18.6, sir. The sodium, potassium, and calcium had also improved. Sodium 136, potassium was around 4, and calcium around 9, sir.
With these findings, what is the final status of the child before you go on to operative management?
The child had improved symptomatically, sir. He was draining urine, sir. There was no history. There was no any complaint of any fever. Child has started tolerating feeds. The creatinine.
So you have basically to, because they are putting up messages about time to cut you short. You have an acute on chronic renal failure, which has improved to some extent and is an established chronic renal failure in a posterior urethral valve. What would be a first line management?
The first line management, sir, as the child has stabilized, so we can proceed for it was established that there were posterior urethral wall. We could proceed directly for ablation of posterior urethral wall, but as adequate resectoscopes were not available for such a small child, so we proceeded with loop ureterostomy on left side.
So if a small instrumentation is the problem, what would be the next diversion?
Vesicostomy, sir.
Okay, so what is the indication? Because there's shortage of time, we'll just jump the gun. What is the indication for doing a supravesical dilatation in a supravesical diversion in a posterior valve?
Sir, if the as in this case the bladder was very small capacity, a highly irregular bladder, small capacity bladder, that would even after vesicostomy, if it would drain or not. And the another thing was there was high grade reflux on left side, sir, to maintain the
posterior urethral valve generally are associated with either reflux or a secondary obstruction at the VUJ causing hydrouretonephrosis. So there are lots of steps which you will have to go through before you straight away say that you did a ureterostomy. Yes, there might be specific reasons in your place which led to that being the first choice of procedure. But in a new posterior urethral valve, when you have stabilized the patient and is in chronic renal failure, you would generally go in the standard protocol of fulguration first, seeing the response, adding on medications if required, seeing how the response to release of the obstruction happens, how much the bladder recovers. This is not something which is going to occur overnight.
Yes, sir.
As far as there is no ongoing deterioration or new symptoms or new problems like urosepsis or something happening, you would not generally go into a primary ureterostomy.
Okay, sir.
Okay, so maybe there are specific reasons why it is there, but there are more of an exception than a rule.
Yes, sir.
And when you're presenting this in a short case, in your exam, you will have to go through very short history. It is more as a patient lying there with a ureterostomy. So you have to talk about examination findings, and then the discussion will be about, why you would do, what would be your serial treatment protocol, when will you do specific procedures, when will you do additional procedures in those indications for ureterostomy, indications for vesicostomy. And if you're doing a ureterostomy, for example, in this child, what makes you choose one side over other when there is a bilateral reflux? So there are lots of these points which will need to be discussed. Okay. What is the role of doing an early DMSA to decide which side is functioning and which is poorly functioning? So all those things will come in your dissection. Because of shortage of time, I'm just giving you as a list rather than asking you the questions. Thank you.
Okay, thank you, sir.
Thank you, sir. Thank you, ma'am. Our next presenter is Dr. Supraja Subramanian, and our examiner is Professor Anand, sir. Over to you, sir.
Yeah, you can start.
So is my screen visible?
Yes.
Good morning, sir. I'll be presenting a short case on a lumbosacral MMC. Coming to the patient overview, it was a 1-day-old female child who was born via naturalis at term with a birth weight of 2.4 kgs. At birth, the parents noticed a swelling in the lower back with turned-in feet and was referred to our hospital at 24 hours. There was no positive maternal history. The mother was booked and immunized, taking her folate supplements till 3 months, and antenatal scans were normal. The mother was not on any medication that did not have any comorbidities. The child voided urine and meconium within 24 hours, had no history of seizures, lethargy, abdominal distension, or poor tone. Coming to key clinical examination, on arrival, we had kept the child on lateral and we wanted to nurse the child in lateral and prone position. We kept a moist dressing over the swelling that was seen. On inspection, head-to-toe examination was normal. There was no syndromic facies. The child had good cry and activity, was pink euthermic without any pallor. CVS, RS, and per abdominal examination were unremarkable. On local examination, on inspection, there was a 3 into 4 centimeters reddish yellow cystic structure visible in the lower back. With the sac appearing intact. There was no leak of fluid present on inspection. The spine appeared slightly scoliotic to the left. The perineum was normal. The anal orifice was normal. It was not moved anteriorly. Bilateral lower limbs showed power of 3/5, and bilateral feet showed in equinovarus deformity. On palpation, the inspectory findings were confirmed. It was a 3 into 4 centimeter cystic swelling present in the lower back at the lumbar junction. It was cystic in consistency, non-tender with no leak, and there were no solid components palpable. It was a brilliantly transilluminant cyst, and the spine was scoliotic to the left. Upper limb power was 5/5, but lower limb power was 3/5 with normal tone. Bilateral feet had equinovarus deformity, and anal orifice was normal with normal anocutaneous reflux. The percussion and auscultation findings did not reveal any information. The head circumference was 34 centimeters. The AF was flat with boom bulge, and there was no transmitted mobility between the AF and the cyst. This was my clinical findings. From this history and examination, I would like to give a diagnosis of a spinal dysrapsin of an open neural defect of a lumbar myelomeningocele.
Okay, just before you proceed, you said this child had a normal delivery.
Yes, sir.
And it was
the antenatal scans were normal, sir. So they were not aware of this anomaly. Otherwise, if it's seen in the antenatal scans, we prefer to have a elective LSCS so that we don't rupture it.
Suppose this child had been born with this lesion and had bilateral paraparesis.
Yes, sir.
When you counsel the patient, what would you be telling them?
So you would have to explain to them that repair of this lesion is not going to bring back the power in both lower limbs. The child is going to be immobilized or on a wheelchair for the rest of his life. Will have bladder bowel symptoms.
So when you have a child with paraparesis after normal delivery,
yes, sir.
Is it always established neurological deficit?
Sir, could be a hip displacement, bilateral hip displacement probably. So we'll have to take an X-ray to confirm. But if there was a lesion such
we're talking about neurological deficit.
Yes, sir.
When you have a normal delivery in a large meningomyelocele or erratic cases like this, you can have a stage of spinal shock, a neuropraxia, and when you counsel, you have to bear that in mind and not give them a bleak prognosis straight away.
Okay, sir. Okay, sir.
The second thing was you said in your clinical examination, you mentioned in inspection that ANS was not anteriorly placed.
Yes, sir.
Why did you think the ANS would be anteriorly placed? What specifically thing would we be looking at when you look at the ANS in this patient?
So we look for anocutaneous reflux and whether it's the reflux is present or not. In case of
on inspection, you said what on inspection will tell you that there is probably some sort of neurogenic component of the bowel.
So it will be pactylous, sir. It will not have its corrugations all around on inspection.
And bladder?
So bladder will be visible in the suprapubic region.
Anything else? Because in your examination, to say that there is no deficit with respect to the bowel and bladder, what else will you do?
On examination, sir, the bladder was not palpable, sir. And
so if a bladder is palpable, does it mandatorily becomes a neurogenic bladder?
No, sir.
What else will you do?
The spine examination, sir.
No, in the bladder.
Would you do something, some maneuver?
So Creed's maneuver.
Okay, so what will happen if it's a neurogenic bladder? What you call it bladder, which starts, where the child starts passing urine when you do a Creed's maneuver.
It's an automatic bladder. I'm not sure, sir.
It's an expressible bladder.
Expressible bladder. Okay,
how would you differentiate this from a newborn or an infant when the bladder is full? When you give suprapubic pressure, they anyway would start voiding.
Yes, sir.
So how would you differentiate this expressible bladder from a normal newborn who has just started voiding because of his suprapubic pressure?
So it would be palpable? I'm not sure,
Palpable.
sir.
You mentioned the word autonomous
Auto-
bladder. That is
Yes,
usually an infant which fills and empties at
empties,
will.
yes, sir.
As it gets filled up, it keeps emptying. In a normal newborn, when you initiate the maturation cycle by a suprapubic pressure, it completes the maturation. Whereas in
Yes,
a
sir.
neurogenic bladder, which is full, when you do a Kreitz maneuver and
Kreitz
it starts
maneuver.
voiding, the moment you take off your hand, it will stop voiding. It is dependent
Okay,
on
sir.
abdominal or external pressure to empty.
Okay, sir.
How else will
Yes.
you test for bowel and bladder incontinence? And you said in the inspection that power was 3/5.
Sir, the child was moving his lower limb, sir. So that's
Moving lower limbs doesn't mean
against
3/5. No? How do you test? If you want to
Sir,
be sure about the bowel bladder, if the bladder is not, see, one is a bladder which is gone into retention type of neurogenicity where it is full all the time and you can express it. But the other
Yes.
extreme will be a bladder which is always empty
Keeps
because
on
of
empty.
incontinence. So how will you complete your examination for neurogenic bowel bladder and the limb power?
Sir, for neurogenic bladder, we'll see if there's continuous dribbling of the diaper, probably.
That is one. What else?
So urine routine examination.
How is the routine going to tell you whether there's incontinence?
Nothing, sir.
So when you examine the baby, you need to hold the baby up vertically. Lift the baby in your hand, hold
Yes,
the
sir.
baby up and look at the movements of the limbs, look at whether there's continuous dribbling from your bladder, whether
Urine
there's
level.
stools continuously leaking out from the anus. Sometimes on examination, it may not appear completely patulous. The moment you lift up the baby starts crying, and that little cry will make the baby continuously dribble, or some amount of stool will keep leaking out every time the baby cries and struggles. And
Okay, sir.
when you lift up the baby, and at that
Child
point
has
of
to
time,
move
if
his
there is
limbs.
movement of the limbs,
Yes, sir.
it is all the joints, the hip joint, the knee joint, and the
Yes.
ankle joint. If
Ankle
it is
joint.
tending to lift up against gravity, then you know that it is at least more than 3. You cannot check against resistance. You cannot do all
Yes, sir.
against powerful significant resistance and all in a newborn. The
Yes, sir.
maximum you can bring it up is to movement against gravity.
Yes, sir.
And in your examination, general head-to-toe examination, you did mention it in your this thing as anterofontanel. Anything else you would want to look for in this child?
Sir, head circumference.
What is the normal head circumference?
Sir, around 34. In a newborn, 34 centimeters, sir.
In a term newborn?
34 centimeters, sir.
What else other than head circumference?
So we'll have to look for how soft the anterior fontanelle is, whether it's tense or flat, sir, to look for hydrocephalus, sir.
What
And
else?
whether there's any transmitted so what's the word? Transmitted mobility between the AF and our cyst, the
See,
myelocytes.
that is okay for a company that not something which would generally be doing on a meningomyelocele, because most of the time the sac is thin. And
Yes, sir.
you
We might
did
have
mention you did transillumination on this child, but if this is the same picture with the child had come to you with, the sac actually looks collapsed. So I'm not sure how you were able to elicit.
Yes, the sac was filled with fluid, sir. It's looking that way, sir. It wasn't leaking, sir, before we
So why
opened.
is this looking collapsed if it is not leaking?
It wasn't leaking, sir.
Must have leaked.
Okay, what else? Vikesh, you said something?
Must have leaked already.
Yeah. So when it is, that is another reason when you are looking at the head circumference and other signs for hydrocephalus, and if this is the appearance of the meningomyelocele, you cannot say that there is no hydrocephalus. You will have to look at other
Yes, sir.
parameters. Okay, what would you do
Yes,
next?
sir, first we'll do our routine investigation, sir. We'll do an X-ray chest, abdomen, and pelvis AP lateral to look for the spine. We'll do a USG spine and a USG of the brain. And if that has any findings, we can go ahead with the CT brain. We'll do a USG KUB to look for the bladder and any upper tract dilatations. And since the child had club feet, we'll do an X-ray foot AP lateral also to get a orthopedic consultation as soon as possible. This was the X-ray of the child, sir, AP lateral. We are not able to see the sacral pieces very clearly, but no other anomalies are seen. The USG actually showed a defect. The USG spine showed a defect in the L2, L5 with herniation of nerve elements and cyst in the choroid fissure, sir. So we wanted to further investigate, and we did a CT of the brain and the with spine screening.
Time up, sir.
So
So
quickly,
the
what will you be
CT.
looking for in the CT?
So we look for hydrocephalus,
Suppose there is no hydrocephalus, anything else you would
and
look for?
Chari2 malformation. So there will be herniation of the cerebral tonsils with dilatation of the ventricles above.
Would you want to do an MRI?
Sir,
Of the
actually,
spine?
MRI is better to do than a CT, but in our
Not for the brain. I'm asking about the spine.
the spine, actually, we were able to get all the information we wanted from the USG. There were no split cords or any syrinxes or lipomas seen in the rest of the spine. And in the CT screening also, we confirmed it. If there were any signs of the split cord or any syrinxes and more proximal, then we would have better to get an
So
MRI.
what would you suppose this child also had hydrocephalus?
Yes, sir.
Which would you tackle first?
Sir, actually, we could do both. If the child had hydrocephalus as well, it's better to do both in the same sitting. Finish the hydrocephalus and then turn the child to a prone position and do the MMC repair. But otherwise, we'll do the MMC repair first and then monitor the child's head circumference to see whether the child will require a VP shunting.
If it's a gross meningomyelocele and the hydrocephalus, you would always address the hydrocephalus first. If
Okay,
it is
sir.
something just a mild variation of the Evans index and it is not tense,
Yes, sir.
dilated,
Yes, sir.
not shuntable, then you can go the standard way of doing the MMC repair. But if it's a gross hydrocephalus,
Do the hydrocephalus.
if your anesthetist, your ICU backup, everything is good enough, you can do it on the same day, or you would do the hydrocephalus, wait for 3-4 days, and then go in and do the meningomyelocele later.
Yes, sir.
Okay. I think we'll stop now because they told me that time is that. So
Okay, thank you,
there's
sir.
still lots of small things which you'll need to know about and discuss, but like the
Yes, sir.
shortage of time, we just covered maybe 40-50% of the main ones. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Our next session is table viva, which is done by Professor Arvind Sinha, sir, AIMS Jodhpur. And next half will be done by Avinash Jadhav, sir. Yes, sir, your screen is visible.
Okay. Right. So we had the table viva, and I think 84 of you participated, and these are the distribution. I think on an average, most of you scored around 60 out of 100 marks, right? So let's go through the questions. The first one was renal tumor, and what was the most common cause of upgradation of chemotherapy during surgery for pediatric renal tumor? And tumor spillage is one of the things which was the correct answer. Most of you got this. Another distractor which we had put was lymph node sampling. That's another factor which surgeon controls that can affect the prognosis. But I think tumor spillage was the right answer. And the second question was about pouch colon and what were the classifications. So it's a condition which is seen specifically in India, and most of the classifications are given by Indians. And Watson risk group classification is for esophageal atresia, and that is the correct answer. Right. Third was about energy devices. What was the principle of this energy device? Some about 35% of you got it wrong, where they believe that the active limb has a combination of mechanical along with electrical energy. It has only mechanical vibrations to cut and coagulate tissue. So answer C was the correct option. Right. What were the functions of the two blade? Another question, the harmonic. The active blade basically generates the mechanical movement, which increases the temperature, and the passive blade is basically to oppose the tissue, hold the tissue in place, right? And that leads to the sealing and those kind of things. So answer C was the correct answer. Again, on harmonic, what are the statements which are true about the instrument? So one of the, it definitely has choice A is one. It has definitely has a lower temperature generation than electrocautery. It produces excessive smoke. It really does not produce excessive smoke. It actually produces steam, which the choice C, and it has vessel sealing capability for vessels only up to 3 mm. The manufacturer claims that the vessel sealing capability is less than 7 mm. People argue it's between 3, 4, 5, but definitely it is more than 3 mm. So I think answer A and C are true, right? This is a question on fan blade lever retractors, and it was mostly a clear-cut answer. Multiple prongs arranged in a fan-like configuration were there. So choice B is the correct option. Uh, yes, in which surgery it is commonly used? It's originally designed for retraction of the liver. So laparoscopic fundoplication, where you need to retract the left lobe of liver, is the correct answer. Yes, many of you have chosen thoracic lobectomy. Yes, it's been used for other surgeries also, these fan retractor. But if fundoplication is present, I would uh, keep that as a choice, but lobectomy also you can definitely use. Right. Then the question on Nathanson retractor blade. How is the retractor typically stabilized during surgery? There were two choices where I think there was confusion. One is basically is attached to a mechanical arm or stabilizing system, and that stabilizing system is then attached to the operating table. So option B was correct. Many of you have chosen clamp to the operating table directly, but we chose the blade specifically so that we could basically make the choice B the default correct option, right? There is a basically if you have the whole system, it'll be clamped directly to the operating table. Then we had lung holding forceps, and the correct answer was yes, holding the lung tissue for obtaining biopsy. You can obviously use it for other things, but I think the correct option is holding the lung tissue for obtaining biopsy. That's the standard answer for lung holding forceps. Uh, um, Benson's pyloric spreader, I think many of you got it wrong. It has definitely has multiple horizontal serration, but they are on the outside of the jaws. That's one of the cardinal distinguishing features. Here, the option was the inside of the jaw, which was incorrect. The tips are blunt to help prevent perforation. This is a correct option. The C option is it has a screw joint. If you look at the joints, there are basically two kinds of joints for instruments. One is a box joint and one is the screw joint. And screw joints are generally used for fine instruments where the arms are overlapping like scissors. That's where the screw joints are used. Box joints are used for most of the things. And you can see in the picture, this is a box joint. So the option C was also incorrect. And it definitely in the picture you can make sure see that there is no locking mechanism. So the only B is true. The tips are blunt to help prevent perforation. All the other options are actually wrong. Right. Benson's pyloric spreader, which is the correct instrument designed for specifically for the clinical scenario of pyloric stenosis, and Benson's pyloric spreader is the correct option. I think people got confused by Ramsted's pyloric dissector. That is also instrument, but what were depicted in the picture was a Benson's pyloric spreader. Then another question was on Finocchio retractor. What was the purpose of rounded opening on the blade of this famous pediatric instrument that we use quite often? One of the things is obviously to decrease the weight of the instruments itself. The initial instruments were designed with solid blades, and then Finocchio basically changed and made the holes. it does not prevent ischemia and all that, but another thing that it is designed for is the herniation of the soft tissue through these holes. Actually, stabilizes the phenocitor retractor in place, but that is not one of the choices in the multiple choice question. So it basically is used primarily to decrease the weight of the instruments, especially neonates. Then the next was on cystoscope, diagnosis of which pathology cannot be made directly using endoscopic instrument, and chalazial diverticulum is a renal pathology. It cannot be made directly. You can do a retrograde urography and all that, but it definitely cannot be used for by made directly or using a cystoscope. Then the next was on resectoscope. What are the three components that are there? Our aim was you should be able to identify the names of the three components. So one is a sheath, the second is obturator, and third is a working element, and that is how it is in order, right? So what is the purpose of the hole in the trocar? So these are the trocars which we commonly use. There's a trocar, there's a hole on top of it, and that is for, it's an optical trocar to insert the telescope for optical entry. And you can make out the tip also, which is basically transparent to allow us for us to visualize as we are entering the tissues, right? There are serrations on the outer aspect of the shaft, and that is basically to prevent inadvertent slippage. And basically, we can tie it, and it basically remains in place. So the aim of these serration is to prevent inadvertent slippage. Capacitive coupling was another option, but that is for metal trocars. Capacitive couplings can occur, and others are just air gap and added strength are just distractors which have been given to you. Yeah. Then bronchoscope and esophagoscope. This is a very common, I think one out of two in your MCH exam will get this question, how to identify a bronchoscope and esophagoscope. And most of you have identified it correctly. Option A is the bronchoscope and B is the esophagoscope. Then there was a question of mastoid retractor. Which of the following feature best distinguishes this retractor from other commonly used retractors? Option one is a hand retractor. Is not a hand retractor. Basically, you basically leave it on the body itself, and it retracts self-retaining. It's partially a self-retaining retractor. It is designed for atraumatic tissue retraction. It has very sharp, actually, it has very sharp limbs, and it is a traumatic retractor. And the one of the distinguishing features is once you apply pressure, it actually normally it closes most of the instruments. Here, the instruments open, jaws open, and there are no narrow blades which are optimized for vascular planes. So the correct option was option C. Mastoid retractor, which common surgery it is used for, and the options we had given was Kimura's duodenectomy, electric reimplantation, PSARP, and spinal surgeries. I think everyone would agree, the most examiners, that PSARPs and spinal surgeries are the places where we typically use the mastoid retractor. Basically, it needs some amount of flat surface on which to lie flat while it retracts the tissue at the front end of it, right? So both PSARP, where it lies on the back, and spinal surgeries, where it can lie on the upper thorax and open the muscle planes, right? That is where we use it. Kimura's duodenectomy and ureteric reimplantation we really cannot use because it's a very traumatic instrument. Then this was a Lone Star retractor, which is a game changer for at least transcendental endorectal pull-through, and most of you have correctly identified this instrument. So, which of the statements regarding this instrument are correct? And here, I think many of you got confused. It's a self-retaining retractor system, which is absolutely correct. It comes in one fixed size retractor ring, as depicted in the slide. There are many different sizes of retractor rings, and even one retractor ring can be changed in shape and orientation by the screws which are present, 4 screws which are present. So it's not a fixed size retractor ring, and it definitely comes with elastic hooks, and it's a disposable instrument. It's made by Cooper Surgical. It's a disposable instrument. We definitely reuse it because of cost constraints. So A, C, and D are correct. It's definitely not a fixed size retractor ring. You can change the sizes. Then this is another common question that you will get. How do you differentiate instrument B from instrument A? Instrument A is a bronchoscope. Instrument B is a esophagoscope, right? So absence of markings on B, generally esophagoscopes have markings on the shaft of the thing. So absence of marking on B, you can visualize, you can see the markings on the shaft itself. So that was an incorrect option. Presence of ventilation port in B. Actually, ventilation port is present in the instrument A or bronchoscope. So this was also an incorrect option. Flattened shaft of the instrument B is another factor which you use to distinguish between esophagoscope and bronchoscope. So these three factors, that is markings, ventilation port, and flattened shaft of a shaft. These are the three things which you use to distinguish between bronchoscope and esophagoscope. Here, by virtue of choices, only the flattened shaft of instrument B is the correct option as a distinguishing feature. Then the 4 ports of a bronchoscope, I think most of you got it right. Port for light prism, the irregularly shaped surface on the side, that's the light prism port. Then there's the ventilation port, which is the large port, open port is the ventilation port, and the small port is for suction port, and straight inline port is the endoscope port or working port itself. And then we had a question on a Maryland dissector, and if you have a Benson's pyloric spreader, that's the specialized instrument. But Maryland dissector is used in pyloric myotomy for spreading of muscle fiber of the pylorus longitudinally. We were used is based this energy device. The instrument is based on monopolar electrosurgery. Most of you got it right. Right. Thank you. I would ask Avinash to carry forward. Yeah, I've stopped sharing.
Thank you, sir. I'll now do the rest of the questions. For the lack of time, I'll first deal with questions where there have been confusion or most have selected wrong answers. Is my screen visible?
Yeah. Yes, sir.
Yes, sir.
Yeah.
Yes, sir.
So this question number 30 was about a hemangioma on the back, and the question was identify the following pathology and pick the odd one. Most of the answer and pick the odd one. So the right answer was meningomyelocele, but still a certain amount of quite a significant people have selected dermal sinus. Actually, a hemangioma without any swelling on the back is a stigmata of neural defects. So meningomyelocele is a very overt pathology. It is not a spina bifida occulta pathology. So I don't know why this had happened. So maybe because of the English they have got it wrong or something. So coming to the next question, where many of them have gone, some of them have chosen a wrong answer. Significant number was about the biliary atresia pathology, histopathology. So in the histopathology of biliary atresia, bile duct proliferation is a significant marker, whereas significant number of people have chosen decreased number of bile ducts as the answer. So I would like to emphasize that it is the portal fibrosis with bile duct proliferation, which is the pathognomic sign of biliary atresia. Now coming to the next question, where there has been a confusion in the answer, is about the CT image of a hydrocephalus. So the image shown was of a non-communicating hydrocephalus That is, the fourth ventricle was not visible. So that is a sign of, see, in this CT scan, the fourth ventricle is collapsed, whereas the lateral and third ventricles are dilated. So this is an
indication.
Yeah, so this is an indication for ETV. Just a minute, so I'll align this. So coming to, so the answer here becomes the non-communicating hydrocaph. It becomes an indication. So coming to the next question, what the question was about the CT features of hepatoblastoma. So it is again a very pathognomic sign there, where there is a late washout with irregular peripheral enhancement of the and central necrosis in hepatoblastoma. So this is the right answer. Significant number of people have chosen a homogeneous appearance as a right answer. Another question was on magic trial. Now, magic trial for GCT. So magic trial is it's a malignant GCT international trial, collaboration trial for for germ cell tumors in pediatric age group. So we in this case, in the stage 1 pediatric germ cell tumors, it helps in early detection of the relapse and thus increase the to make the survival improve the survival outcomes and reducing the chemotherapy effect. So the C was the best answer amongst the options. The options were very close to each other, but you had to read it very properly. Coming to the VUR, then there was a MCU select for VUR, and you asked to select the grade. So most of them have made a mistake. So this was the MCU which was given. So here we can clearly see the calacial anatomy. What has happened with the calacial anatomy? That was your in that was the sign that you have to pick up to select the grade. Many of them have selected grade 4, but actually it was a grade 5 because it was a blunting and clubbing of calacial there. Although the ureter must relatively the ureter appears not that tortuous or dilated, but this is a significant sign that has to be picked up. Coming to the another question, which most of them would have quite a significant chose a wrong answer, was about the MIBG scan. So the use of MIBG scan is for the the adrenal pathologies, whereas it is in papillary carcinoma, it is not that pathognomic. The next question was where there was a lot of confusion amongst the choices, or a wrong choice was selected by most of the people, was about the use of CUSA. So either the identification must have gone wrong. So this was the image. This is a probe of CUSA. CUSA is cavitary and ultrasonic aspirator, which we use in cases of hepatoblastoma and neural surgeries. So the principle of this is it uses ultrasonic waves to cut the tissues. It selectively spares the nerves and vessels, and it aspirates the tissues that we have that have been destroyed by the energy. So aspiration is also a part of the process. So here the option A was the most correct one, where suction is required. Okay. And the question which the other question which most of them have got wrong or got confused was this image. So this was an intraoperative image of a fluorescent dye that was given. So this is an indocyanine green study. Okay, it is used mainly to identify in the liver pathologies as well as in other pathologies where we have to identify the vascular structures or lymphatic structures. But the route and the timing, the route of administration of the dye and the timing of the administration of the dye differs for every pathology. When we have to use it for liver and colorectal and biliary tract diseases, for our indications, the dye has to be given at least 18 to 24 hours prior to the surgery, so that it gets concentrated in the gets enough time to get concentrated in the liver, and the excretion can be visualized when we are doing the surgery. So this was the best option, that when is the dye should be given for the particular liver pathology.
Route of
So
administration also, someone is asking.
yeah. What did you say, sir? I did not get it.
Route of administration, someone is asking.
Yeah, the route of administration in this case has to be a intravenous route of administration. If we have to use it for, say, some identifying a lymph nodes in particular cases, then you can, or a lymphatic leak, then you can use it in the lymph nodes, and various other routes are there locally, depending on the pathology. So these were the questions where most of the people have got confused, or if they've chosen a wrong answer. So I think so that should be done, or should I go through all the questions? I did it for this saving the time. That completes the table viva run through for the questions which were. Hello.
Yeah, Arvind sir, you want to say something?
No, I think ICG wala was the thing. Normally adults they would give the for CBD and all that, they were 30-40 minutes before the procedure, right? But in our cases, 2-month-old biliary atresia, typically we give overnight, day before, so that it actually collects in the liver itself. That was the, I think, differing point. Otherwise, for adults, we would probably give 40-45 minutes and 5-10 minutes for vessels only. Yeah.
Yes, because of the liver pathology, the concentration time can be different, so that we have to give it earlier than the adults.
I must say, sir, your team made an excellent quiz, and it included all mix of like simple questions, difficult questions, all variety, all situations. A lot of hard work has been done on that quiz, sir. It is very evident. Thank you very much for it, sir.
Thank you so
Thank you,
much.
Avinash, and thank
Yes,
you,
sir. Thank you, sir.
Siva Kamesh.
Yes, sir.
Over to you, Vinay. Vinay?
Thank you, sir. Thank you, sir, for such an insightful session. Now we have X-ray Viva session conducted by Dr. Rahul Deo Sharma, sir. Over to you, sir.
Thank you, Vinay. So now we are going to start with the X-ray session. I'm going to share my slide, and you can see on the slide. And if Vikesh sir is will going to reward you, okay, and no negative marking basically. So I'm going to start just now. Is my screen visible?
No, sir, not yet.
Just a minute. Is it visible now?
Yes, sir.
Can you set the
So-
rules? I mean, this is a like live round, so how would you like participants to participate or reply to your question?
Yeah. So whosoever wants to give the answer, raise hands and unmute yourself and give the answer. Okay. And if no, yeah, and if no one is going to answer, then I'm going to show the answers. So can you identify this X-ray? Yeah. So it is a case of CDH. Okay.
One having
Good one.
dual devices, because there is echo. I mean, two devices in one room.
Uh, Not at my place, sir.
Okay, now it is look like someone is there.
Yeah. So now the second X-ray. So now what's the answer? It is an interesting one. Anyone? No one knows this is. So this is a
Sir, you
case of,
can see the comment section also, sir. Few of them are answering
okay.
there also.
Okay, so it is a case of event ration with sec. Now this is the another one. If you can see an answer. So this is a case of CLE. If anyone wants to ask me anything, you can ask by unmuting yourself. Yeah. So now what's the answer? So this is a case of CCAM. As you can see, the variety of the CCAM.
Rahul,
I think most of you will.
It will be
Yes,
good
sir.
if you can describe key findings on the basis of which you make the diagnosis.
Sure, sir. Sure, sir.
We give you
So
that.
I think this is going, yeah, I think this is going to be the easy one that you people can identify. This is the most routine we people are seeing. So this is a case of esophageal atresia with tracheoesophageal fistula. You can see the coiling of the tube there in the X-ray, and gas is present in the abdomen. So that will make a tracheoesophageal fistula with esophageal atresia. Yeah. So now this case. So if you can notice something that I have described in my last X-ray.
Is a pure.
So this is a case of pure esophageal atresia. There is
Pure
no, hello?
gas
Yeah.
in the
So there is
abdomen.
no gas in the stomach. There is no gas. As you can see, that is a classical finding of pure esophageal atresia. Now next one. So as you can see, this is a case of pyloric atresia. You see a large bubble is there, single bubble sign. Now who can identify this? It is a case of very common one, double bubble sign. Double bubble sign, yeah, duodenal atresia. Everyone gets double bubbles? Now what is the finding? You see a classical, another classical sign. How many bubbles one people can see? So this triple bubble. Okay, so triple bubble signs in proximal jejunal atresia. Now this is a difficult one. If you people can know. Anyone? So what it is, paucity of the gases. As we can see, there are no gases, and it is a case of malrotation. Yeah. So this is a contrast X-ray, as we can see. What is the answer for this? Upper GI contrast. How you're going to say it is going to be a malrotation or non-rotation? You have to see where is the crossing, where you are going to cross. What is the sign for malrotation in upper GI contrast? Anyone? Is I am audible? I can't hear anyone. Hello?
You are audible, sir. Many of them are answering in the comment section.
Okay, comment section. I think it is a live class. They can just raise hands and unmute themselves and answer. Because to go in the comment section and see, for me is little difficult. So can you unmute one by one who is raising hand? No one.
Someone has written corkscrew sign, someone has written.
So now we have another interesting case. As you can see, it is a case of gases are there in the stomach, there in the bowel, gases are there, but yeah, so it is a case of small bowel obstruction. Good, I really like it. Good one.
Can I ask one question to all the postgraduates? You see a large air fluid level extending. Can you go to the previous slide, Rahul?
Yes, sir.
So large air fluid level from one end of the abdomen to the other end of the abdomen. If you trace it like it's the same fluid level. So why not it is a giant cystic meconium peritonitis or perforation? Anyone can answer? So differential diagnosis.
No calcification.
One, there is no calcification, obviously. Yes, good point.
No free gas in the diaphragm.
In giant cystic meconium peritonitis, you won't get free gas because it is an antenatal event. So the same picture you can get in GCMP, and calcification is not must. It is unlike meconium ileus, where you may get calcification. So not always calcifications are there. So I think one DD ileal atresia associated with GCMP is there in this patient.
Can be, sir.
Okay. Next exit.
Yeah. So this is a babygram, as you people can see, with some gases there. What's the diagnosis? So as you can see, this is a babygram with prominent loop of bowel. That is a classical finding for NEC. And what you are going to do in this patient? Anyone? So if you get a prominent bowel loop of NEC, what you will do? Either conservative or surgical. So you are going to do the conservative management with the follow-up with the X-rays. Okay. And if on follow-up X-rays, you see it is going to be there adhered and the clinical scenario of patient is worsening, then only you go for the exploration of the patient. So now what it is, as you can see, this is a contrast X-ray. You can see whole bowel, what it is going to be. Anyone? So it is a case of malrotation. How you notice the malrotation? The same previous I showed you. See where is the small bowel, where is the large bowel, where is your stomach, and where is your pylorus, and where is your duodenum is going. On the basis of that, you would identify it is a case of malrotation.
So there is like someone has not understood it clearly, Rahul. You go back. See, if you see this X-ray,
Yes, sir.
I'm able to mark it, but the stomach is seen, then the pylorus is seen, pyloric sphincter is seen, then duodenum is seen, and then you see this is a duodenal C, which is more on the right side. The third and the fourth part of the duodenum is on the right side, DJ. This is the duodenojejunal junction, and you can see the dilatation of the duodenum throughout. And bowel is on the right side. This is what This X-ray mean to say, but the definitive diagnostic feature may be probably a ultrasound Doppler, where you can see superior mesenteric artery
Yeah.
and relationship.
SMA, SMB. Yes, sir.
Artery is on the right side in malrotation. Reversal. That is the reversal of relationship. Okay.
Yes, sir.
Someone was like putting question mark there. That's why I elaborated it.
Okay.
Okay.
Okay, sir. Yeah. So I think this is the classical X-ray with the contrast. Every one of us can answer it very easily.
Total colonic ganglionosis, I guess.
Yeah.
Contrast enema with microcolons.
So it is a case of microcolon. The diagnosis can be, it can be a case of TCA. Okay. What else it can be?
Simple meconium alias.
Yeah. So you can say sometimes pellets can be there, or sometimes microcolon can be there in the meconium ileus.
Or it may be ileoatresia also.
It can be
No.
also, sir.
Go
The
back.
same picture, the microcolon.
Go
You
back.
can see.
Yeah, because you can
Yes,
see
sir. I'm back, sir.
dilated jejunal loops here. I can see dilated jejunal loop, distended stomach, although there is no air fluid level. But there is definitely proximal GI obstruction in this case. And the probable cause may be a jejunal atresia with a microcolon. You can't be sure about it, but
100%. So same picture of a contrast enema, as you can see with the microcolon there. It is most probably going to be a Hirschsprung disease, and there is no dilated proximal intestine, as you can see in this picture. So now what's the DD? Again, a contrast picture. Anyone?
it is
So
not
it is a
adequate
case of,
answer. You have to specify the transition zone also. Yes, right. Who is this Mai? Someone is saying ultra short also. How it can be ultra short?
no, it cannot be ultra short.
Someone is answering ultra short. It's a long segment Hirschsprung disease. The T
Okay, sir.
is at splenic flexor. No? Where is the TZ?
Yes, sir.
Transition zone is at splenic flexor, I guess. Because there is dilatation here of the transverse.
Yes, sir. Yes. So, but it is a case of TCA.
TCA? Okay.
Yes, sir. It is a case of TCA. That
Why this
transition zone
dilate?
looked like at the splenic flexor, but it was not the case.
Okay.
In this case, we went up to the ileum, and it was there at the ileum from the ganglions in this case, sir.
So this transverse colon, why it is dilated? Yeah, okay, fine.
Yeah, so this is an unusual picture. I don't think we should show it in the exam. It will kill the candidate.
Okay. Next.
Yeah. So what it is, you can see the contrast is there. It is going down. Then you can see this picture also.
Classic.
Yeah. So it is a case of classic Hirschsprung disease.
So there we call it like reversal of the rectosigmoid ratio. See, these are technical words. Whenever you describe X-ray in exam, it is always a good habit to first identify the X-ray, what X-ray it is, name it like this is a barium enema or whatever, contrast enema. Then second, identify the radiological findings. So here it shows narrow rectum, then narrowing, and then there is a junction of dilatation in the narrowing at the level of rectosigmoid junction, dilated proximal colon suggestive of megacolon, and reversal of the rectosigmoid ratio. So my radiological diagnosis is a classical Hirschsprung disease involving rectosigmoid junction. That is how you should describe the X-ray in exam. This is what we have been taught and we have been teaching. It's always a good habit. Thank you. Next.
Yes, sir. Next X-ray, as you can see, a contrast X-ray with a very good finding, as you can notice. So I just told all of you. So a case of, again, long segment Hirschsprung disease, as you can see, where is the transition zone is there.
Somewhere at the sigmoid to a descending colon junction, right?
Yes, sir. So how much more time I have, sir?
How many X-rays do you have more?
Sir, I have many.
No, but you can cover like urology and all those, no? GI, if you have covered, you can avoid repetitions.
Oh, okay, sir.
Avoid repetitions.
Yeah. Yeah. So as you can see, this is a upside down. Previously, we used to do upside down. Now we are doing it in lateral. Because of very famous pediatric surgeon of ours. So this is a case of invertogram. Okay, now we are not doing the invertogram. We are doing cross table prone lateral.
So you have to describe this X-ray. Can we go back?
Yes, sir.
Can someone describe this X-ray? Anyone? Come on. Supraja.
Yeah.
Supraja, describe it. Are you there in the meeting or left?
Yeah, yes, sir. So this is a invertogram, an X-ray of the abdomen and pelvis with a coin kept as an anal marker. In the first X-ray on the left side, we can see a dilated colon, which is probably crossing the PC line, but not the I line, sir. Whereas with no dilatation of proximal bowel, small bowel that is, in the right side invertogram, it's a similar X-ray with the coin kept as an anal marker, and we can see the dilated bowel coming up till almost up till the anal marker, sir.
Yeah,
so probably the right side is a low, is an ARM with imperforate anus with a low anomaly, and the left side
Yeah, right.
is
Are
probably
the invertogram properly done?
Sir, sir, if we had done this as a PTLV, we would have kept something below the abdomen, soft pads to push the bowel gas up.
Look at the
But
X-ray.
the two greater trochanters
That is the
are
most
not aligned well, sir.
Yeah, so it is not a properly done invertogram. Ideally, you
Yes.
should be able to see overlapping of the greater trochanters. Pubic symphysis should be visible, exposure should be good enough, and coccyx should be clearly visible so that you can mark the PC line.
Yes, sir.
Next.
Yeah. So next one, very important for all of us and very interesting one, if you can answer.
Answer karo, Vidisha. Unmute and answer.
So, this looks like a pressure augmented distal colostogram. Uh, with I guess there is spillage to the bladder also. So my diagnosis will be a male ARM with rectovesical or recto urethral fistula.
I think see it, you look at it properly. Look at
Yeah.
the lateral film. First thing you should not see the bladder. First thing you see look for the tapering. Where is the tapering?
The tapering, I guess, is going towards the
Bulbar urethra.
prostatic urethra, bulbar or rectobulbar urethra,
Bulbar urethra, below membranous urethra.
below membranous
The
urethra.
level of membranous urethra. So this is like it is Contrast has gone from urethra into the bladder, not from rectum into the bladder.
Yes, sir. Yes, sir.
Okay? So now
Yes.
don't jump on the bladder. First see the rectum. Okay? Rectum and look for the tapering. Tapering is at this level. So it is
Okay,
not a
sir.
prostatic fistula. It is a membranous or a bulbar fistula.
Bulbar fistula.
Probably a bulbar because this terminal portion is not enhanced. Why it is not enhanced? Because there is a sphincter around it.
Yes, sir.
Not a very good pressure colostomogram.
Yes, sir.
That is why you need pressure for that. Okay, next.
Okay, sir. Thank you, sir.
This is again Hirschsprung or what? We leave this one.
It is again Hirschsprung and distal cholesterol.
We leave it. It's a very, clear-cut one, yeah.
Yeah. So this is what, if anyone can. Anyone?
So this is an ultrasound film. I give the hint that this is a case of acute abdominal colic in a 6-month-old baby with recurrent vomiting.
Sir has already given you the hint, and it is the answer also.
Viral,
Interception, I guess.
Viral, open your mic and answer it and describe the finding and differential diagnosis of such a finding.
Sir, this is actually ultrasound. Sir, we can see the hostration of the bowel, sir. Actually, it looks like an interception where bowel is going into the bowel, where the interceptor is entering into the interceptum, sir. The midline, there is a mark between the two bowel we can see.
It's called as target sign.
Target sign, sir. And sir, actually the interceptor is visible entering into the interceptor, sir. In the middle, actually, sir.
So what you see white is what, and what you see black is what in ultrasound?
Sir, actually,
hyperechoic and hypoechoic.
sir, hypoechoic actually. Hello.
No, there are multiple layers. No, there are various layers.
Yes, sir.
So how do you identify? Muscle, and how do you identify mucosa on ultrasound?
Sir,
Okay.
mucosa will be hypoechoic.
Mucosa will be hyperechoic. And this is a transverse section where you get target site.
Yes, sir.
Where else you get target site? This echo somewhere, two devices. Target sign, where do you get target? I think Rahul's phone is also on and laptop is also.
Yeah, just a minute.
And all your WhatsApp chats are visible. Okay, fine. Let's close this session and we can again repeat it somewhere in the next online meeting, totally dedicated to X-rays. We can have one later on.
Yes.
No, Rahul, is that okay to you? Rahul, is that okay to you? Okay, fine. So now we move on to the next session, and that the debriefing of the theory paper. Professor Kanish Das sir is there. Sir, over to you, sir.
Right. So, good. Those of you who have taken the theory paper seriously and answered it. So I have mailed back all the evaluation sheets and the comments in it to each of you. Please go through that. And if you have any doubts, get back to us. Also mailed is a blueprint of the answer key and the marks. And then you will know why in that particular section you have got that particular marks. And most of the examiners have given you comments which are listed there. So there were a panel of 12 examiners, Dr. Bagdi, Dr. Pawai, Dr. Sasish Agarwal, Dr. Anand, Aladi Anand, Dr. Lakshmi, Dr. Prema, Dr. Ruchirendu Sarkar, Dr. Hemant Datta, Dr. Sashank Panda, and Dr. Narendra Babu, Dr. Ravi Kishore. So all of them have, many of them, at least 2-3 of these people have seen each of the candidates' papers. And I have gone through all your answers of all the students too. So there are some general points that I will make to you. As you would see from the question paper, the variety of questions are, some are unstructured, like the questions, some are semi-structured, partially structured, and some are not structured. They're short notes. So in each of them, we see different attributes of your answering, whether you are able to classify your thoughts and write them. In the semi-structured ones, we see whether you are able to take the hint of what is what and not miss out points. And in short notes, we see whether you can convert a very big content to a small crystallized content. Read the question papers properly. In one of you have, instead of writing about stage 5 Wilms tumor, you have written the 5 stages of Wilms tumor. That way. So read your question paper properly. Divide your timings. Don't, in the beginning, leave a little time for your revision in the end, and then divide the rest of the time depending on your marks. Do not spend more time on a question just because you know more in that, or you have read more in that. So don't overspend time on a question. Allot according to the marks and use that, because finally you are aiming for a score here. Handwriting, if it is legible, then you, for the same content, you get more marks. Remember that. Invariably, it works on the psychology of the examiner. So don't take that, underestimate neat writing. Content, do not think that if you repeat content, you will get more marks, because if you write the same point twice, you will still get the same marks. So don't waste your time. Don't repeat content. Do not miss parts of questions, because if you have attempted the part, even if you have not written substantial, there is a point of some mark coming in there, even if it is 1 out of 4. So you will still gain. So N marks, do not leave any sections or part of questions. Attempt all the questions. I'm sure you will know something about them. Common mistakes are in management. When we ask management, we expect that you will write investigation and treatment both. So some of you have missed, and if you miss investigations, you really don't think management is only treatment. Just like etiopathogenesis is etiology, pathology, pathogenesis. So if you miss something, you will just lose out the marks there. So be careful. Don't underestimate short notes and focus only on long questions. Long questions might look grand, but short notes also will give you marks for the same. And so don't miss out on writing key points in short notes and grabbing those marks. Write in points. Many of you have wasted your time writing full sentences and texts. You will not gain anything there. So practice writing in points so that it is understandable. It is easily readable, understandable, and the examiner doesn't get confused and doesn't have to hunt for points inside your text. So use headings, use subheadings. That gives the examiner an idea that you are clear and you know how to go about systematically putting your content. Just like Vikesh mentioned, use specific terms. We are looking for very specific terms, keywords, whether it is in Viva or whether it is in theory. So when we see those keywords, it rings a bell and a mark flows out. It is that way. So even the blueprint that is given to examiners, etc., has keywords in them, and they're looking for those keywords, especially in national board exams, if not elsewhere. Where possible, use an algorithm. It will not only save time, it will tell the examiner that you are clear and you don't have to repeat text. So use an algorithm, use a table or a diagram. It implies that you have understood something much better than another person who hasn't used it. When there is an easy question, like here, there was a question on empyema thoracis. So all the examiners expected that you will write it well because it's such an easy question. Go to the second question, the Wilms tumor question. That was not such an easy question. So there, if you miss out on some points here and there, it doesn't matter. But if you miss out on common things in empyema thoracis, it makes a big difference. So that is how you must differentiate. So there's always a temptation to write a whole lot of things in empyema, which is an easy question, and don't spare time for the other. So don't get into those traps. Divide your time and use time appropriately. So just to give you an example, the long question on Wilms tumor, the first part was, what is stage 5? So it's just a question which is looking at whether you know the definition of stage 5. So what is stage 5 is basically whether you know the definition, and if you write some cardinal features, then it adds to your marks. It raises up your marks. But if you do not write the definition and you're vague, you will not get the marks there. The rest of the question was on the diagnosis and treatment of stage 5. So the key points and terms that we were looking for was, is there a role of a pre-op biopsy? Some of you only have written it. Neoadjuvant chemotherapy, that term was extremely important. Reassessment time frame. So at 6 weeks, at 12 weeks, the surgery must be done by 12 weeks. Those are the key concepts there. Nephron sparing surgery as a term, that was very crucial there. Then the importance of bilateral affliction, renal failure as a threat in prognosis, and the overall outcome. So these are the key terms that the examiner was looking for. The moment we see those terms, we know that you have the concept right. For the short note, an example of the short note was Hirschsprung's disease. What were the key terms there? The key terms there was rectal biopsy for diagnosis, leveling biopsy to see the extent. The two features, many of you have written this, absence of ganglion cells and the hypertrophic nerves. Some of you have missed even that. Those are cardinal things in this diagnosis. You can't miss them. Those of you who have written about frozen, about partial thickness, full thickness, or calretinine, you get the higher points. But at least the basic must come. If the rectal biopsy, leveling biopsy, ganglion cells, hypertrophic nerves are written, you will easily get 2 out of 3. In a question on recent advance, they're a little tricky. You may or may not know the recent advance. But if you have this sort of framework to write some content, you will definitely get some marks. Introduce, what is that? At least you would have heard of it. If you know the principle, then that is good. Like here, the principle of robotics versus the earlier minimally invasive surgeries. So the principle was important. The applications. Any recent advance, we are looking for translation and applications. So in robotics, the applications that you have mentioned, you've given examples of pediatric applications. And many of these things come into adult first and then later down. So pediatric peculiarities. Many of you have written this particular short note well. Now, last point that I wish to make is, some of you, you know who, some of you, you would identify yourself, have used the net or chat GPT to do that. So be careful. You are only fooling yourself. We can easily make out a content which is written from your experience and your knowledge than what is taken from a chat GPT format. They are all very general formats. So yourself, be true to yourself, and you see how you have scored in your evaluation. Yeah. Any questions from any of you or Vikesh or anyone else? I've mailed the answer sheets to all of you, the evaluation sheet. Yeah. We can't hear you, Vikesh.
We come to the concluding session, and that is we want to discuss with the audience about the feedback and what else can be done better in future activities related to students. So you can open up your mic as well as your video And if you have any suggestion, I know there must have been many deficiencies. The biggest one was like we were not able to give adequate time for discussion. I agree totally. But at times, like in 4 or 5 hours, we have to cover so many topics and we want to give opportunity to many presenters. So we have to rush also. Hope you understand. Apart from that, if there is any other suggestion, we are very happy to receive them, as well as in our future endeavors, we will try to improve upon them. Any student, any question to examiner? These are two very revered examiner, Professor Das and Professor Sinha, and a lot of hard work has been done to create this program. Anyone, any suggestions? Good, or you want to give negative or positive feedback? All are welcome. No one saying anything, sir. Sir, you would like to say something, Arvind Sinha, sir?
Yeah, I think a very decent program. I think paucity of time was definitely there, and normally one student or two students will examine in 4 or 5 hours. Here we've tried to include 10 or odd students with table vivas and everything in that. So the problems of the format is definitely there, but wonderful, I think, initiative. I think students should participate a little bit more and be unafraid and open up and speak. This is now mostly an informal session. Yeah.
So Dr. Biswas sir is still there with us. So Biswas sir, would you like to say something before we end the session? So meanwhile, I thank and congratulate our two young people who conducted the show, Dr. Vinay Shelke and Dr. Rashmi, who is a MS surgery resident with us. So thank you very much for giving your
Thank you, sir.
day. Thank you, Kanishka Das. With this, we close this session.
Thank you. Thank you.
Thank you very much.